Good morning, everybody, and uh, good, welcome to all of you for the live operative webcast of the RIRS from Sham Urological Center from Ahmedabad. Dr. Kanda Parik is the operating faculty. This is the USI ISU initiative, and we have Dr. Nanjappa and Dr. Tanuj Pal Bhatia who will be moderating this session. I welcome both of them for the moderation today. And with this introductory remarks, I would now request Dr. C. Mallikarjuna, President USI, to give his opening remarks. Over to you, Dr. Mallikarjuna.
Thank you, Keshav. I think it's a brainchild of this webcast every month. I think it has become very popular. I think one of the most popular things which has happened in USI is this live operative webcast, which is happening every month. And I'm thankful to majority of the members who have been instrumental in coming forward to do this webcast from their own setups, though it is a very difficult thing to do. But I think today I thank Kanda Parik to do this job on RIRS, and Dr. Hamri and Dr. Olivia, who have come from, who are going to join this meeting today, in spite of their busy schedules. And I thank the moderators for today's and the faculty today, Dr. Mahesh Desai, Dr. Nanjappa, and Dr. Tanajpal Bhatia to spend their weekends on this workshop. I think this has become a norm of in future. I think majority of the workshops, webcasts are going to happen in this fashion, and the people can watch from their homes without without traveling it. I think our audiovisual transmissions are going to be of that nature that everything can be told through this webcast itself. I wish all the best to this webcast, and go ahead, Keshav.
Thank you, Dr. Mallikarjun. Now I would invite Professor Rajiv Sood, Chairman of the Indian School of Urology, for his opening remarks.
Thank you, Keshav. President Dr. Mallikarjun. This is the first workshop after our Dean of Urology, Dr. S.S. Bapat, is not with us, and we all remember him. Having remembered him now, I want to bring greetings from Indian School of Urology. This is the systematic programs which are being conducted, and you know that 5 levels of competency are now introduced by National Medical Commission, and it is the highest before performance. That is the show how level. That is the 4th level of competency, and we are very happy that what we were envisaging, that we will be doing all these programs through digital platform. Even before pandemic, we had thought that, and we were working for that, and it was called Euromet V virtual, and we are successful in doing that, and it is very effective. As our president has just mentioned, we have eminent faculty from India. Dr. Mahesh Desai is there, and Dr. Said bin Hamari and Oliver Texter. We welcome them and hope that this moderation by Najappa and Tanuj Pal Bhatia is going to add more and more flavor to this workshop. This is the series of workshops which are being done under this USI ISU initiative, and these are becoming very, very popular and very, very effective, and are also archived every after. And Dr. Kanda Parik, who has been with the, when I was talking about level of competencies in our initial competency levels, that know how that Euromet simulation programs were there, and he has contributed a lot, and he has come with the coffee book also. That is also going to add the treasures of Urological Society of India. Congratulations to all of the members of this subspecialty. Thank you, and back to Dr. Keshav Murthy.
Thank you, Professor Sood. Now I would invite Dr. Nanjappa and Dr. Tanuj Pal Bhatia to take over for the moderation. Over to both of you. Over to you, Dr. Nanjappa and Tanuj.
Good morning. First of all, I would like to thank ISU and USI for this opportunity. And good morning, everybody. Good morning, Tanuj. And over to you to right away hit it and start it.
Yeah. Thank you so much, sir. So good morning, everyone. Without wasting any time, I would like to invite the first speaker, Dr. Vikram, to give his talk on instruments and accessories in RIRS. Dr. Vikram is graduated from, he did his MCH from SRMC Chennai and is currently working as a consultant urologist at Sri Paduka Specialty Hospital, Trichy. He has been instrumental in holding many hands-on and live workshops on RIRS and spine PCNL, and he's very active in RIRS academics as well. So welcome, Dr. Vikram. Please start with your talk.
Yes, the slide visible?
Yes.
I thank the Urological Society of India and Indian School of Urology and the organizers for giving me this opportunity. Good morning to everyone. I'm going to talk about the instruments and accessories for doing RIRS. Is the slide moving? Yeah.
Yes.
For successfully doing the RIRS, we need to select the right set of accessories and the instruments. In this talk, I'm going to cover the flexible ureteroscopes, guide wires, access sheets, and stone retrieval devices. The selection of energy sources and the options will be discussed as we are performing the surgeries. I've tried to compile a list of things that are commonly available in Indian market and doesn't have any specific reference to any specific company, and the copyright belongs to the companies who have manufactured it. The flexible ureteroscopes have evolved over a period of 2 decades, right from having single side deflection to double side deflection, and then secondary deflections, and thicker scopes of 11 to 12 French size to thinner scopes of 7.5 French, and then the digital scopes, and then comes the disposable digital scopes. For ease of understanding, we can classify them into fiber optic reusable scopes, digital reusable scopes, and then digital disposable scopes. Each comes with its own advantages and disadvantages. We'll see one by one. The fiber optic reusable in Indian market, 2 are major companies. One is the FlexX 2S from Karl Storz, and other one is P7 from Olympus. Both the companies give a deflection of about 270 degrees both ways, and the working channel is similar 3.6 French, and the FlexX 2S has a 7.5 French outer diameter, and Olympus P7 has 7.9 French outer diameter. Both of these can be used for primary RIRS. We all know that the Indian ureters are narrow, and for doing primary RIRS, it's better that we have a narrow, thinner scope. So this can be accommodated into your 9.5, 11.5 access sheet. So this is going to be a workhorse till the digital scopes are going to get thinner. So for any center who's doing RIRS, it is probably good to have a fiber optic scope, one of these, so that we can get into the narrow ureters comfortably and complete the case in single sitting. This is a model, special design of Olympus, which has a bullet tip. Though the shaft is 7.95 French, the tip is only 4.9 French, so that we can easily gain access into Nora infundibulum and difficult to enter calyces. The vision is very good, and both the FlexX 2S and Olympus P7 visions are comparable. Coming to the digital reusable ones, the FlexX C is the foremost one, has been there for a long time with excellent vision, and the outer diameter is 8.5 French. This has to be used with 10-12 French access sheet. Xishan is a Chinese make with 8.5 French, and again it can be used at a 10-12 access sheet. Basically, the difference between the digital and the fiber optic ones are, the fiber optic ones are heavier to use, but it has the advantage of using with any of the camera systems that we have, the single chip, the HD ones, the older ones, new ones. Almost all the camera models can be attached and used comfortably. So that is the advantage of having a fiber optic scope, whereas the digital scopes come with their own working systems, their own monitors, their own cameras. They are also portable, especially the Xishan one has a very small camera and monitor unit which can be accommodated in a suitcase and taken wherever you go if you are going roaming and doing practice. Again, buying a digital disposable one or a reusable or a fiber optic scope is a matter of debate by itself, and this is beyond the perspective of this talk. Coming to the digital disposable ones, there are nearly half a dozen scopes available in Indian market. I've covered the few prominent ones. The BioRad, which is proudly made in India, it is an 8-French scope, can be used with a 10-12 access sheath, and this can be classified as a multi-use disposable for Indian market. They give a life of about 31 hours, after which the light source will stop working. But again, it not necessarily come for all the 31 hours. It can get damaged even within a few cases. So that has to be borne in mind when they call it as a disposable one. The build quality will be substandard or not up to the mark of digital reusable ones. The Pusan is another prominent one, which is 9.5 French, can be used with 11-13 access sheath. V-scope is from US. This claims to have a 7.5 French, can be used for a primary RARS in a 9.5, 11.5 access sheath. And comes the LithoView from Boston Scientific. It can be used as it's a 9.5 French scope, can be used with 11-13 access sheath. Again, as the technical refinements are happening, the digital scopes are getting thinner. Until the day the digital scopes compete with the 7.5 French of the fiber optic scopes that we have now, the fiber optic scopes probably are part of all our armamentarium to do primary RARS. Coming to the guide wire, we need guide wires for the placement of access sheath. And in case of difficult or ureter with multiple kinks, we may have to introduce the guide wire and then thread the scope through that. And without using the access sheath, we can also use the guide wires to pass the scope. And for stent placement. Of these, the hydro twister guide wire comes from various Indian manufacturers. This has a hydrophilic tip and a stiff cobra-like body. So this causes minimal injury to the pelvic alysial mucosa while we introduce the access sheath, and is very valuable. And this has become a one-stop shop for all our guide wire needs. We can have entry of the semi-rigid retroscope, we can pass our access sheath, we can pass it for ascension of the scope, and we can do stenting with this. And bi-wire is a special wire which has both sides floppy tip. One will be an angled one and other one will be a straight one. The angled one can be passed inside the pelvic alysial system, and the straight soft tip can be introduced into the flexible scope, so that we can ascend the scope without use of access sheath. The commonly used one is 0.32 inch size. Coming to the access sheath, there are various makers of access sheath. The commonly used ones are the Cook, the Boston Scientific, and from Indian manufacturers like BioRad. This comes with outer sheath and an internal dilator. They are radio opaque so that we can see it in the C-arm. The outer sheath will have a hydrophilic coating so that the chances of ureteric avulsion is reduced. And though they are introduced as single use, we do use it repeatedly. So it is always better to inspect the hydrophilic coating before every use. And this can be introduced over a guide wire under fluoroscopic guidance. The internal diameter varies from 9.5 to 14 French, and the external diameter from 11.5 to 17.5. We have to select the right ureteric access sheath for whatever scope that we are selecting. And the length again varies from 20 to 55. Probably the optimum would be 35, which would suit most of our Indian heights. The advantages of using ureteric access sheath is that it dilates the ureter, it improves the drainage, thereby improving the vision. It eases multiple entries and movement of scope inside and outside, especially very useful in case we are picking up the necrosed papillae or to pick up the broken stone fragments. And this significantly reduces the intrarenal pressure, thereby reducing the chances of sepsis, improves the longevity of the scope, and definitely reduces the operating time. Comes with its own disadvantage that it can cause ureteric injury if not properly introduced, and it can cause ureteric ischemia if it is placed for a long duration of time. It is always mandatory to inspect the ureter with a semi-rigid ureteroscope for friendliness of introduction of the access sheath. There are various stone baskets. Again, the prominently used ones are Cook, which we have been using for more than 12, 13 years now. And we have recently entered Boston Scientific and from various manufacturers. I have covered the ones from Cook and Boston Scientific. The prominently used models are the N-circle and the N-gauge ones. This N-circle model has a tipless design. So there is minimal trauma to the mucosa where we pick up or drop the stone. And it definitely permits full continuous deflection of the scope. It is in terms of deflection, this is much better than the N-gauge model. This gives that extra deflection and ease of stone manipulation to reach difficult areas. But this has to be used with caution. If we don't assess the infundibulum, whether the infundibulum is friendly enough to allow the removal of the stone from an undesired calyx, sometimes there is a chance that we can get stuck. The basket can get stuck along with the stone if we don't assess it properly. So we have to use it with caution. The advantage of this N-gauge basket is that this holds like a basket and release like a grasper. So in case you are stuck in a difficult calyx, there is always a chance that you can disengage the stone, drop it to the same calyx, and then rework on a different plan to break the stone. But the disadvantage of this is that it needs a groove. We need to have a groove in the stone for this to work effectively. In smooth round stones, we may not effectively catch the stone with this type of basket. Another advantage of this basket is the assistant need not be extremely skilled to handle the basket. Even a beginner can comfortably hold the stone with this. Whereas N-circle needs some good orientation for the assistant. This is a very nice basket from Boston Scientific. It has an inner channel in the basket itself, which can accommodate 200 micron fiber so that the stone can be broken with the help of fiber. This also has another escape mechanism. In case we are stuck in an undesirable area, we can open the cage from 11 mm to 15 mm so that the stone can be dislodged and the life of the scope can be prolonged. This is Dakota basket from Boston Scientific, which again has a similar mechanism of action to the N-gauge basket from Cook, but again with a built-in escape mechanism of opening that extra to drop the stone. Coming to the adapters, these are very important to keep the rate of irrigation constant and to reduce the leak of irrigant fluid at the level of entry of the working channel and to fix the laser fiber and reduce the accidental damage of the fiber or the scope. Every manufacturer comes with their own type of adapters. This is a Tuhai adapter. This is a piece of plastic that comes with every Cook basket. And this is very valuable if you are using the Karl Storz products. So if we are using Olympus, they have their own design of adapter, and all the disposable scopes also come with their own model of adapters. This is a special flexible biopsy forceps, which will be handy in case of need of histopathology from upper tract. This has a detachable handle and a flexible shaft. So we have to introduce the basket or rather the forceps retro from the tip of the flexible scope and then attach the handle, go inside the system, and this has a cold cup like mechanism to obtain sample for histopathology. Thank you.
Thank you, Dr. Vikram.
Wonderful.
Yeah, so please go ahead. Please.
Good presentation, Vikram. Actually, exhaustive covering of all the aspects of the accessories. Now, if I'm a newcomer and I would like to buy my first scope, what would you recommend? What should be my first scope?
So that's a highly controversial thing. I was recommending Flex X2 earlier, saying that was the thinnest scope available and it can be used for several cases. But now my recommendation has shifted to the BioRad scope, which can still be threaded without the access sheath. So, and I feel after training lots of newcomers, they feel comfortable that way, that they don't have to worry about damaging the scope. So that is a very big advantage of these disposable scopes, so that they are comfortable. The beginners are comfortable. But in long run, probably till the disposable scopes come with a thinner shaft, probably a fiber optic scope should be there in our armamentarium. We have actually the Olympus P7, the Flex X2, the Flex XC, and Biorad. All the 4 we have.
Dr. Vikram, you said that Biorad scope can be passed through a 10-12 French access sheath. And Dr. Abhishek from MPH wants to ask you that is it true that you can use it every time with a, can you use it through a 10-12 sheath actually in practice?
Yeah, it is going. We are regularly using it. Actually, that is the only scope as of now we are using regularly with 10-12 access sheath.
And you have decent outflow. Yeah.
Yeah, we have decent outflow. The point is, Biorad had a 9 French one, and then now they are coming out. They are claiming it as 7.5, but it is actually a 8 French one that goes in a 10-12 access sheath.
And the access sheath you are saying is the Cook access sheath or the routine one, because there is a Rocamed access sheath with a wider inner diameter. I agree that some might go through that, but is it actually going through the Cook access sheath? You can tell better.
The 10-12 access sheath for Biorad that we use is from Blonim. The Blonim Indian one is what that we are using.
Okay, thank you.
Thank you.
I think now is Kandarp ready over there, Ravi?
Yes, sir. We are ready.
Yeah. So can you present the first case, and if Kandarp is ready, then can we start the...
Yes, sir. So good morning, everybody. Excellent kickstart to the morning by Dr. Vikram. And we start this operative workshop with the first case. And are the slides visible, sir?
Yes.
Yeah, they are visible.
Okay. So the first patient is a 62-year male patient who was presented to us with right flank pain for the past 1 month. He is diabetic and hypertensive, well controlled. His investigations are within the normal limits. His urine culture was positive, E. coli sensitive to cephivant tazobactam, for which he was preoperatively treated with antibiotics, and now the urine culture has turned sterile. This patient presented to us with right flank pain. So the patient had right renal and right lower ureteric calculus, for which right URS and RIRS, and bilateral degestenting was done in view of bilateral stones. So the patient today is for the left RIRS, where we will be operating for a left 11 millimeter lower calacial cal and a 6.6 millimeter renal middle calacial cal. The Hounsfield is close to less than 1,000 units. So over to you, Dr. Kandarp, sir, for the left RIRS. Thank you.
Good morning. Nanjappa, good morning to you, and Tanuj, good morning. Thank you, USI and ISU for the lovely opportunity to me to demonstrate 2 RIRSs today. We have lined up 2 cases. In my first case, I have planned to explain you about the various accessories and the instruments and the laser machines what we are using. And I will mainly focus on the technical aspect of stone fragmentation, dusting, because it's a lower calycial stone. Maybe we can grab the stone from the lower calyx and put it into the upper calyx. I do not know what we are going to get inside and what will be the anatomy of the pelvic calycial system inside. But let's see. Let me begin with what I have in my setup. Right now, I will not probably cover the part which is already covered by Vikram, but I will just physically demonstrate whatever we have and whatever scopes we have. He talked about 3 types of scopes available in the world market right now. The fiber optic flexible scope. So in my practice, I have FlexX2S with me. This is FlexX2S. It's a lovely scope. You can use, and you can use even P7 from Olympus. That's also a very, very good scope. The basic difference between the FlexXC and FlexX2 and Olympus P7 is one where the shaft of the Olympus P7 is very stiff, like a ureteric catheter. So if you want to backload the ureteroscope over the guide wire, I think probably you will do a better job with P7. And the vision is also excellent. But FlexX2 is very much, the maneuverability of the FlexX2 is much nice, so that I personally prefer to use FlexX2S in my practice. So this is FlexX2S, the diameter is 7.5 French. So it can easily go through 9.5 French ureteral access sheet. So this is a 9.5 French ureteral access sheet. And the outer part and the inner part, this is a Cook ureteral access sheet. So you can easily insert this ureteroscope through the lumen of the ureteral access sheath. So you can see it. You can see this, right? So this is
Yes, sir.
9.5 French ureteral access sheath and 7.5 French shaft. Now,
Yes.
for the digital scope, we have FlexXC from Carl Stores. And the important feature of this digital scope is that there is no connection for the light cable because there is an inbuilt LED inside and there is no camera attached to this. So again, it's a very good scope. Vision is excellent. And in my personal practice, I always prefer to use FlexXC. That's my personal preference. You can use the URF V3 from Olympus also, or you can use a BOA scope from Wolf, or you can use Cobra, which is slightly bigger in diameter. There are basically two types of scopes available in the world market, the American model and the European model. The American model we have when they are also called as a logic model, where when you, this is a deflection lever. You can see this is a deflection lever here. It is in a neutral position. So when I am deflecting my lever down, the tip goes down. You can appreciate it very well. And when I deflect my lever up, the tip goes up. So they call it as a logic movement. While there are some European model where when you put a scope, when you deflect it down, this is a BOA which I have in my practice with me. So this is a deflection lever. So when I am deflecting it up, the tip is going down. I hope you can appreciate it very well.
Yes, sir. Yes.
And when I'm deflecting it down, the tip is going up. So this is European also call it as a logic model. So
Yes.
but we call it as a anti-logic, right? So this is a BOA scope. This is again 7.5 French. The BOA company says that you can insert through 9.5 French ureteral access sheath. So I'll try to insert it through 9.5 French ureteral access sheath by Cook, and it can easily go inside. The only problem is that it's not only important to insert the scope in the ureteral access sheath. It is very, very important that whenever you are operating, you get a very good backflow also. So with this, you are not getting a very good backflow. So I will not use it for with the 9.5 French ureteral access sheath. I will use it for the 10-12 ureteral access sheath. That should be very clear. You can insert it, but it is not important only to insert. You should get a very good backflow, which is very, very important. So this is a BOA scope. This is the anti-logic or a European model. Now, for these are the digital scopes. Now, for the disposable scopes, in my practice, I have got two scopes with me. One is a Boston LithoView. This is a lovely scope. Actually, they are actually pioneer in the disposable scope, other than the one which was released long back, and now it is not available in the market by Luminous. But this is Boston Scientific LithoView. 9.5 French is the diameter.
Yes.
So you have to use 11, 13 ureteral access sheath. It will not go through 10, 12. So this is 11 French Boston ureteral access sheath. You can see this, and it can easily go through it. Can you please hold it? It can go easily through it, and you get a very good backflow. But when you try to, because it is 9.5 French, please do not insert into 10, 12 ureteral access sheath. So it has to be very, very clear. It's not only important to insert the scope, the good backflow, I'm repeating again, good backflow is mandatory. So this is a Boston lovely vision. I think we'll try to use it in one of the cases. And this is finally, Vikram talked about the invasive limited use ureteroscope. Though it is a disposable scope, we use it several times, and it has a time limit of maybe 30 hours. And again, so this is again the European model. When I'm deflecting up, the tip is going down. So this is BioRed invasive scope. This scope you can insert. This is 7.5 French in diameter. So you can insert it through 10-12 ureteral access sheath. Can you please give me 10-12 ureteral access sheath? So this is a 10 French ureteral access sheath by Rocomed. So it can easily go through it. And there is a good fluid return also. Second, if I try to insert it into 9.5 French ureteral access sheath, please give me 9.5 French ureteral access sheath. Because this is 7.5, let us see whether it goes through this 9.5 or not. Now I'm finding it difficult to insert it. Okay, so do not think that it is 7.5, so it will go through 9.5 French ureteral access sheath. So it is very, very important point one should understand. So these are
Yes.
the scopes. These are the scopes I have. Any question regarding these scopes, Tanuj or Nanjata?
Sir, between
Kandar, I just
the
wanted.
yeah. Yes.
Sorry,
Sir,
Kandar, I
between
just wanted to ask you that
Yeah.
if you recommend a 9.5 French as a universal access sheet, or you recommend 10-12 as a universal access sheet, which would
Okay,
you
so
recommend as a?
in my practice, I recommend 10-12 ureteral access sheet one should use. The advantages are that you can use both the flexible fiber optic flexible scope, or you can use even a digital or the disposable ureteral scope. So 10-12 ureteral access sheet is most acceptable. The ureteral access sheet, as you know, has got two parts: the outer part and the inner part, which I have covered in my book also very well, the different components, and it has got a hydrophilic coating over it. So whenever you are inserting in the patient's body, don't apply jelly over it. You have to lubricate it with the water so that it will lubricate the surface and it will allow your smooth insertion of the ureteral access sheet. Ureteral access sheet should not be forced in the patient's body. There is a debate whether one should use ureteral access sheet routinely or not. In my practice, I'm a big fan of using ureteral access sheet, and if you use ureteral access sheet, a new ureteral access sheet, and gently, you are unlikely to cause the trauma to the ureter if you are using the 10-12 or 9.5 French, 11.5 French ureteral access sheet. There is a beautiful paper by my mentor, Dr. Olivier Trexler, regarding the ureteral access sheet related injury, and it is, but in that paper, the incidence is very, very high, and of the ureteral trauma. The reason being that the ureteral access sheet which was used was 12-14 in diameter. To reduce the ureteral access sheet related injury, if you have pre-stented patient, probably your work is very easy and your insertion is easy and you can avoid injury. But routinely, I do not pre-stent my patients. But if you are in an initial phase of practice, maybe it is a good idea that you stent the patient for at least 10 days. 10 to 1 week to 2 weeks is a good time. 10 days is the best time. And then you go in, I think probably your job will be much, much easier. So this is 10-12 ureteral access sheet, which I use because the diameter, the average diameter of the ureter, if you take, is about 10 French. So it can accommodate an instrument which is up to 10 French in size. That's why 10-12 ureteral access sheet is used.
So there is
Okay,
a
so
question from
I think Nanjap, can you
YouTube.
start the case and you
Yes,
can
sir.
keep on discussing?
okay,
Yes.
fine. So I think okay, we will go straight to the case, and in this patient, the patient is in the lithotomy position. Can you come here, please, cameraman? So patient is placed in a lithotomy position. Patient is under general anesthesia. I prefer to use surgery in general anesthesia, and we during the COVID time we have done many cases under spinal anesthesia also, but it requires a little bit of patience and a proper understanding of the patient about the procedure, and you have to explain it repeatedly to the patient that to hold the breath during the procedure so that the respiration is under control while you are doing a procedure under spinal anesthesia. Here, the patient is under general anesthesia. I got Dr. Rahul Soni, who is my associate, and he is going to assist me. And I got Dr. Paresh Mehta, who is an anesthesiologist, a very well experienced anesthesiologist. And the anesthesiologist plays a very important role in this because so many times during the surgery, you have to tell the patient, the anesthesiologist, to control the respiration. Because if the stone, especially when it is in the upper calyx, there is a lot of respiratory movement, and that will make your task difficult. So that time, anesthesiologist can produce hypoventilation, or it can decrease the tidal volume, so that the respiration is under control and you can fire the laser nicely. So now, for the irrigation, we are going to use we have got many devices. This is a single action pump from Boston, and in routinely in my practice, I use extension tube with the 2 syringes or a gravity irrigation. When I stand here during the surgery, my monitor is on my right side. There are both CR monitors on my right side, and the laser. We are going to use 35-watt Conta laser today, which I use routinely in my practice, and the CM lies on the left side. It is important that when you are doing the procedure, ergonomically you are comfortable, and your eyes should be in the straight line with the monitor, so that you don't have to twist your neck like this many times. Okay.
Yes.
So in this patient, we have already put a ureteral access sheet to save the time, because I wanted to cover this part. In the next case, we will show you how to insert the ureteral access sheet. Here, the ureteral access sheet is already in position, so I will mainly focus on insertion of the scope and the laser lasing technology and the
So
technique.
which access sheet are you using today?
This is,
What
I have
ureteral
used a
access?
Rocomate 1012 ureteral access sheet.
Okay.
This is my favorite, so that I can use either digital scope FlexX C, or I can use FlexX 2. In first case, we will demonstrate vision with the FlexX 2 to begin with, and then I'll switch on to FlexX C, so that you can appreciate the difference between the both the scopes. So, any questions so far?
Kandar, how have we arranged your trolley?
Okay,
Arrangement of your trolley?
okay, so normally this is not the arrangement what we have in a regular day, because I wanted to
Do you
demonstrate.
recommend a special trolley or something? A special
this
size
is,
of the trolley?
Yeah, this it should be long enough, so that you can keep your scope straight in a straight line. And I normally place my trolley underneath the patient's leg. So I am standing here. There is no assistant here, so that I can take equipment from this place and put it myself. So I don't have to have assistant with me. Assistant can stand by this behind me, like Dr. Rahul is standing, right, and he can help me as and when required, right? So in this patient, you can see the ureteral access sheet in position. There is a guide wire. One important thing: park the guide wire like this, what I have parked, which is here in the at the upper thigh, which is very close to the patient's body. So many times the people put a jacket of the guide wire here. So many times when you put a Terumo guide wire, sometimes it slips out of the system. So it is very, very important that you fix the jacket here. Can you appreciate
You
the
always
jacket
use
position?
yeah, we can appreciate, but do you always use a guide wire, Kandar? Safety guide wire?
No, this is not a safety guide wire. This is a guide wire which is coming out through the ureteral access sheet.
So when you put your scope in, you'll have to take out that wire.
Of course, I have to take out. Now there is a lot of discussion about need for the safety guide wire. Yes, according to EAU and AEA guideline, you have to keep the safety guide wire because it saves you from any disaster. But in my practice, and I'm sure that in your practice also, you must have noticed that putting the safety guide wire in the ureter, 2 guide wires in a ureter, along with the ureteral access sheet, sometimes it is very, very difficult. I'm sure that you must have noticed that in your practice also. So routinely, I don't use a safety guide wire. I use a safety guide wire when we have got some previous uritic surgery, solitary kidney. These are the situation, anomalous kidney. In such a situation, I keep a safety guide wire. Otherwise, normally I don't put a safety guide wire. So now what I'm going to do is that backload my scope. This is my FlexX 2S. This is FlexX 2S. The only problem with this, you can see that when you are backloading the scope, there is a camera attached, there is a cable attached, because you have to do a bite balancing. So sometimes it is very, very clumsy. So that's why I don't now prefer personally to use FlexX 2S. But when you initiate the practice, I think it is very, very important that you use
Do you always have to backload your scope over the wire, or you can just, because you already have an access sheet in place?
Okay, so that's a very good, that's a very, very, very important question. Now I'll show you why I want to backload it over my guide wire. That's a very important question. So many times when you are doing RIRS, you get a upper ureteric kink. So when you don't have the your guide wire in the position, in that case, what will happen? You have to travel the ureter, the large part of the ureter, very long length of the ureter, beyond the tip of the ureteral access sheet. So sometimes when there is a
fluoro.
yeah. So now can you please? Yeah. So can you show the fluoro, please? Fluoro.
Any tips in backloading scope, Kandar?
Yeah, you can. You have to keep it straight. You can see that my scope is here. I'm holding my scope in my hand, and this is a guide wire coming out. And now I think I'll have to focus a little more.
You use a special wire? Sorry.
Yes, sir.
Sorry?
Yeah,
go
so
on.
You're not using a bi-wire today, right, sir?
Not today. And actually, I heard that now Cook has withdrawn bi-wire from the market. This is what I heard. I'm not very sure, but I think I got that information. So why I put the guide backload my scope over the guide wire, because that makes my job easy. Like in this patient also, can you please show?
Can we have the endo view and the fluoro view as a smaller image?
Yeah, yeah.
VIP?
Okay, fine, fine.
We can see the scope
Yes.
as reached.
Rahul, Ravi Chan? Now we have connected this extension tube with the syringe. Before you connect it, you have to flush it with the saline so that there
We
are no
have a
air bubbles
surface-
going in. And now I
surface
connect it, so
view.
the assistant can stay very much behind you, so he is not interfering in your surgery. So now my scope is almost reaching into the kidney. Yeah, we are in the kidney. You can see
Yes.
there is a stone
Can you
here.
Can you show how to hold the scope? What is the most
Yeah, okay.
ergonomic way of
Okay,
doing
fine.
it?
Perfectly all right. I'll just show you it in a minute. Just have a look at the vision of this scope. This is a FlexX 2S from Karl Stores. The vision is okay as compared to what we get it with the digital scope. That you will appreciate the difference. And yeah, I'm just, first of all, I'm inspecting all the calyx. So you can see the calyx here. I hope that you are getting a good vision.
Yes, sir. Yes.
Yes, we are
So,
getting a very good.
okay, so I'm inspecting each and every calyx, even if I know that my stone is in the XYZ calyx. So I withdraw, and I'll show you my all hand movements also in a minute. Okay.
Do you put any contrast before going in? Is it recommended, Kandar? Doing an RGP before going in?
When I started doing RIRS, I used to put contrast in every single patient. The only problem with the contrast is that it will blur the vision to begin with. Normally, I believe that you should start your procedure within 5 minutes. You should be at the stone. 5 to 7 minutes, you are at the stone. While when you put the contrast, initial 2-3 minutes, you have to wait for the contrast to clear, because the density of the contrast is different than the density of the water. So you have to wait, and you spend some time. So I don't need to put a contrast when I in my routine case, but I put the contrast when I find difficulty in localizing the stone. Sometimes it is very difficult to localize the stone. So in order to understand the anatomy of the pelvic LSL system, it's a good idea if you put a contrast. Now here you can see there is one more stone here. Can you please show the Siam, please?
Stone,
yeah.
For a beginner, for a lower pole stone, would you recommend to do a contrast study before? Because in this case also we have a plain CT, I believe.
I don't know.
Because there's always talk about the angle and the.
Yeah. So you can, the anatomy will be very clear if you, this is a lower polar stone, you can see here, right?
Yes.
So you can see the Siam also. Are you getting the Siam image also?
No, we are getting the surface view. And
can you please show the Siam? Can you please show the Siam image, please? In the PIP. Can you see it now?
Yeah. Yes, we can.
My scope tip is deflected. Can you see it clearly?
Yes.
So this is the vision of, this is the FlexX 2. So this is lower calyx again. I'm coming out. This is the middle calyx.
There was a stone in the middle calyx also, no?
Yeah.
6 mm stone. I think both have come down.
Sorry, no. The stone is still there only. I think I will show it to you in a minute. Okay, so I just take out my scope now just to show you the vision. I just inserted this. Now you are asking me why you are backloading the scope over the guide wire. Okay, so just imagine that I am in the pelvis now. You can see that narrowing.
Yeah.
Nanjappa.
Yes.
Now I am withdrawing. You can see the access sheet. So you have to travel this much of the distance without the guide wire. And sometimes now this you make your job difficult. You can understand there is a kink here. So what I have to do is that now if I want to be safe, I can, with the experience, I can go in like this. But sometimes you find it very difficult. So in the beginning of the procedure only, you start facing the problem. You are frustrated. So it is important that you don't lose the winning battle. I always say so. So always try to, once the guide wire is in position, why not to use it? That's the only reason you backload it. Okay, so I just take out my scope and I will insert the FlexXC. Okay, so please arrange it. Now,
from the audience, sir.
Now, Tanuj, you were asking me how to hold the scope.
Yes,
Can
sir.
can I tell you?
Yes, sir, please.
Okay, so this is my palm. So I'm holding the scope like this. You can hold it three way. You can hold it with your finger like this. You can hold it with your palm like this completely, or you can hold it like palm and finger grip. I always call it a palm and finger grip. So now with RIRS, you do 4 movements. With the left hand, you are doing 2 movements. One is going in and out like this.
Yes, sir.
Okay. And secondly, what you can do is that you can twist the scope little bit. So supposing if I bend it little, then you will appreciate it. With this, the tip moves. So this is just to focus your laser fiber over the stone. So this 20-degree movement you can get it with this left twisting movement. Don't do it too much, otherwise you will break the fiber sometime.
Yes.
With the right hand, what you do is deflection up and deflection down. So this is the movement with the right hand, deflection down, deflection up. This is one movement, and another which is very crucial movement is palm in and palm out movement. Why you need this? Just appreciate this. So I'm operating, this case I'm operating on the left side. Can you see the tip, Kanuj?
Yes, sir. Yes.
Tip of the scope? Okay.
Yes,
So
sir.
now if I want to go to the middle calyx, the middle calyx comes from the lateral side.
Yes,
So
sir.
I have to move my tip like this. So with
Yes, sir.
my right hand, what I will do is that I will do my palm out.
Yes, sir.
Can you appreciate this?
Yes, sir. Zoom out,
When I'm
please.
doing palm out, palm in, my tip goes medial laterally.
Yes.
Okay, on the opposite side. So you can even think that do opposite. When you want to go on the, supposing if you are operating on the right side and the middle calyx comes on the lateral side, what you do is that palm out. Can you appreciate these two movements?
Yes,
The
sir.
tip, yeah. So you don't have to, some people they use their shoulder to move the tip of the scope on the lateral side. You don't have to do that. Simply with the hand movement only, you can do it. With this movement, you can appreciate it.
Yes.
Yes,
Okay.
basically
So you
think
can make,
opposite. That's right, Kanda.
yeah, think opposite. Okay. So now
Okay.
I'm inserting a flex XC. And now you very soon you will find that the difference in the vision. Can you please connect water with this? And your assistant has to push the fluid very gently. Okay. Don't be careful about the intrarenal pressure.
Can I
Okay.
ask you a question
Any-
from the audience, sir? There are a few
Now,
questions from the audience.
Nanjappa, if you don't have the guide
Yes.
wire, you have to enter like this. So this much distance you have to travel without the guide wire. And if there is a kink, sometimes you make your job difficult.
Okay.
Okay.
Vision
So
is
I'm
excellent.
entering again. Now look at the vision.
Yeah, it's excellent.
You can appreciate the difference in the vision. Is another calyx. You can inspect each and every calyx. You can see the papilla beautifully. Okay, so this is upper calyx is examined. And then I
Is
go
there any
into
difference
the,
in the weight of the scope, Kanda, with your Flex XC and your
yeah,
Flex X2S?
Flex X2 is much heavier than the Flex XC, and the LithoView, Boston and Indovisive are, the disposable scopes are much lighter. So you can inspect each and every calyx. I'll go into the lower calyx first. You can see now both the stones here. Nanjappa, can you appreciate
Yes.
this?
Yes.
Both the stones
yes.
have come here. So what I'll do is that just to demonstrate how to grab the stone from the lower calyx and put it into the upper calyx where the scope tip remains straight. So either I can put it here or I can put it here. Sometimes people try to put the stone always in the upper calyx. It's not necessary. The important thing is that the tip of the scope should be straight and you should be comfortable firing the laser. Sometimes it could be a middle calyx also. So you have to understand that point also. Now, can you please give me the basket? I can break this stone in the, because the infundibulum is good, I can break the stone here in the lower calyx also.
Yes.
Okay, so you want me to grab it with the basket and demonstrate that?
Yeah, you can do that. Which basket are you planning to use?
Okay, so I have many baskets right now available with me. I'll be using, this is what basket you are giving me? This is a Jipo from Biorate. You can use a grasp it from Boston, which I normally use. So this is a Jipo, the same, it is like a grasper. It opens like a jaw and hold the stone. And so it's very easy to release this stone. So it grabs, it repositions, and it releases. These are the three functions of the basket. Okay. So for inserting the basket, can you please give me this is very important thing. You must have this 2 adapter. So I'm putting this 2 adapter here. This will
The
allow.
FlexXC conduct.
Yes.
Yeah, the FlexXC, the channel, the working channel has got these, lure lock adapters. Is it justified to have a lure lock adapter there?
Now I
where
think
you are now?
that's up. I mean, I'm habituated. I mean, I'm fine with this. I have no problem. But you, even if you don't have it, it's okay.
Okay. Now,
So
sometimes if you close
yeah,
your
if you try,
lure lap adapter
yeah, if you
with
try
a,
to close the
yeah,
you can see my basket coming in.
yeah,
Okay, so now you have to fix this basket here so that there is no water leak, and the basket is fixed now. I cannot move. If I want to move the basket, I have to slightly release it. Okay. So
okay.
now with the basket, this is 2.2 French, right? The 2.2 French, I am going in the lower pole.
So for a lower pole, you recommend a 2.2 or a 1.7?
1.9 is the best actually. Okay, I have reached to the stone. Can you see that?
Yeah,
Okay,
we
now
can see that.
open the basket, please.
So there's an assistant who's going to do that for you, right?
Of
Opening and
course.
closing the
But I have to
basket.
help him to grab the stone. If the stone is very big, probably it will not catch. So let's see now.
So now you're holding your scope with your left hand and you're doing this with your right hand, or you're doing
No. I'm holding my scope with the right hand. My left hand is
Very
free.
good.
I'm just supporting the scope with my left hand. I don't have to hold anything.
Very good.
I'm just pushing with my left hand. I'm pushing the basket in and out, and in a desired position. Can you please grab it now? So Dr. Rahul has grabbed the stone, and I'm trying to remove it. Grab it and remove it. Okay, it has slipped out of the system because the stone appears to be very long and big. You can appreciate it's a long stone, huh?
Yes.
So I have to grab it from the periphery, hold it. And then I'm trying to remove it. Okay. And now you can see it that the stone is out here. Now I can put here, wherever I want to put, I can put here, or I can put maybe here. I'll put it here. Now, can you please show the scope tip? Siam, please.
Kanda, do you assess where to place the stone on endoscopy or on fluoroscopy? You do it on endoscopy only?
Both. You can see the position of the scope now. It is in the middle calyx.
Yeah.
Still, I feel that this is very comfortable for me. I can put it here also, or I can go into the upper calyx. But upper calyx sometimes it's if the entry of the upper calyx is very narrow like this. You can see it.
Right.
It is very narrow. I don't. If I want to push it here, I'll make my job difficult. So that's why I am putting my stone here. And now Dr. Rahul will release it. Okay, the stone is released. Can you see that?
Yes, beautiful.
Yeah, okay, now we'll close the basket
tip
completely.
On the distance, Kanda, any tip on the distance of the stone from your scope tip? Because when you're moving it, you will not have any idea of where you're going to. So anywhere where we have a distance, you should maintain a distance between the stone and your scope cut tip.
I didn't get the question. Sorry, Nanjappa.
If the stone is very near your scope, you will not have any vision at all. So is there any distance?
So that's why if you have noticed that I extended the tip of my basket little more so that I could see both the stone as well as the open basket completely, and then I released it.
Excellent.
Now I will be inserting a laser fiber. In this patient, I'm going to use 200 micron fiber. Normally I use 200 micron fiber, but you can use 265 micron fiber also. So I'm inserting the laser fiber. When you insert the laser fiber, again make sure that the tip of the scope is straight. So for that, the deflection lever should be at the neutral position, and always check it, confirm it by Siam. So can you please you can see the upper calyx here. So now more or less my tip should be straight, but you can see the tip now. Can you see the tip, Siam vision?
Yes.
So now I can insert. Whenever I'm inserting, if I get a resistance near the tip of the scope, I just have to wait and again readjust. You can see the fiber is coming out of the accessory channel. This is a digital scope, so the accessory channel is at 3 o'clock position. If it was FlexX 2, it could have come out at 9 o'clock position.
Yes.
Okay, so
how
I'm
much
reaching
do you
to the
take out the tip of the laser fiber from the scope? I mean, how? far away
Okay, fine.
should we
So
take it
now you
out?
can see
Any
this
tip on
is
that?
this tip. You should be able to see this blue part, and you can see that my tip is occupying almost 1/4 of the screen. You can see the screen. Okay, then you are safe to go. So it means that this tip is almost 3 mm outside my scope, tip of my scope. So I'm safe to fire the laser. Right now, we'll start with in this patient, I can do two things. I can either do a dusting and or else I can fragment the stone in some few pieces and take out and do a complete clearance. Okay.
Can you just guide us through the laser settings? If how you have set
Yeah.
your
So
laser,
to begin with, because right now what I'll do is that I'll try to produce little bit of the dusting. So yeah. So now what I'll do is that you can see that my laser settings are the energy is 0.7 and the frequency is 12. I can go to frequency of 15 and energy setting to 0.5 also. Okay, so you can start with the lower setting, but in my experience, I have seen that with this quanta laser, 0.7 energy and 12 or 15 frequency sounds better. So total power we are using is 8.4 watt because 12 is the frequency and you can see that.
Can we set the pulse width on this laser? Is it
No. You put it on a dusting mode, and the machine will automatically set it as a long pulse width. If you want to do a pulse dusting, you can see that you can see, first of all, appreciate the stone is very steady. Now all credit goes to anesthesiologist. He is doing so. My job is very easy. Okay, supposing if the stone is moving too much, in that case, I will not be able to do a precise job like this. And I'm producing a very fine dust. I could have broken the stone in few pieces and speed up the procedure. To finish the procedure in 5 minutes is not a difficult job, but you have to do a complete job. That's what I personally believe. So I would always like to produce a very fine dust which can come out on its own. So sometimes we don't put even a double jet stent. So in that case, probably it will be easier for the dust to pass on its own, or you keep the double jet stent for at least 7 to 10 days and do confirmatory X-ray and take it out.
Do you set your laser setting for any stone? This will be your laser setting for dusting, or it depends on the size of the stone?
No, it depends on the size of the stone. It depends on the HU value of the stone, and always begin with the low setting, and then gradually you can ramp up the setting level as and when required, whatever you want to do. Suppose if you want to do a fragmentation, you increase the energy. That's a joules you increase to from 0.7, you can go to 0.8, 0.9, 1 joule, and you can reduce the frequency because frequency usually speed up the procedure. The role of the frequency is to speed up the procedure, and the role of the energy that's measured in joule is to fragment the stone. In almost every patient, I produce a good dusting. I spare 5-10 minutes more in the operation theater, but you can discharge the patient quite early with satisfaction. And then you can, when you reach to the center of the stone, you can. It's very difficult to produce a dust that you will appreciate it. And then in that time, what you do is you simply fragment the stone and take it out for the stone analysis. Sometimes we stand even the stone culture also.
So now what's your plan for this stone, Kanda?
What is the plan for this stone?
So what I'm doing is and you will have,
What I'll do is that I'm just fragmenting, dusting little more, and then I take out, grab it with the basket and take out the fragment, so that we can produce a complete clearance, almost a complete clearance, and we make a note of every patient that this is what we have done in the patient for this patient. So we know exactly whether we'll be required to take out the double jet stent under local anesthesia or general anesthesia. By and large, it gives you a rough guidance.
Kandap, as the size of the stone comes down, do you decrease the setting so that the stone doesn't move, or you continue with the same
now, I have
settings
kept my settings fixed, but if required, yes, I can do that. But right now, you can see that the stone is not moving at all.
Yes.
this much of the movement of the stone is perfect for me, no problem. Now I have to reduce the stone to a small size so that I know that now if I grab the stone, probably it wouldn't be difficult for me to take out the fragment. This fragment can easily come out, and this is, mind you, this is a digital scope. So if you now if you
Yes.
keep it like this, you will appreciate that the fragments are very tiny. If you go very close, it will appear very big. Okay, so that is also very important. That some people even make a popcorning at this moment and then they call it a day. That also you can do it. Okay, so let me see. This is done.
Any tip to get the size of the fragments? We'll come to know endoscopically what would be the size of the fragments.
Okay, so if you, this is 200 micron fiber. So if you keep this 200 micron fiber close to the stone, you can appreciate that this stone is approximately about 1 mm in size, about 3-4 times bigger than this, at least 2-3 times bigger than this. So you can roughly you can estimate that all these fragments are about 1 mm in size, less than 1 mm some of the fragments, and so you even if you may not take it out also.
Generally, do you like to take out some fragments, sir?
Yeah, I will certainly take out some of the fragments for the stone analysis.
Which is your preferred basket for that, sir?
Now for this is such a small stone, probably it will be very, this is upper calacial stone. Can you appreciate that?
Yes, sir.
There were 2 stones, Nanjappa.
Yes.
And we can
So
see.
this is another stone which I will make a dust. And I know that I have to give you operation theater back, the mic back to Dr. Saeed at 10:30. So I think we'll finish before that. No problem.
We have time.
You're doing an excellent job, Kandar.
Thank you so much.
So, Kandar, anything about your cleaving the laser fiber? Do you always cleave it? I mean, only cut it, or do you even strip it?
No, I use
The laser fibers nowadays.
I use unstripped laser fiber. I believe that it is not necessary because if that white glass fiber is projecting, it is very distracting to eye. And you must have noticed that even there is no pilot light. You can see, appreciate, because sometimes pilot light also distracts. So you can keep it on a minimum setting. I keep it at a one setting of 1 because it distracts. If you increase, can you increase the pilot light? Just to show them. Now you can see the pilot light. Now this is very distracting to my eyes, so I don't like it. So I don't want to keep it more than 1. That's all. That's enough for me. Yeah, especially I think in a digital scope, it will distract you more than in a fiber optic scope. Correct. So, right. So any tips? I mean, if it's a newcomer who's doing it, should the aiming beam be on or should the aiming beam not be on? It should be on, but keep it minimum. Keep it minimum, okay. Keep it minimum. Sometimes look at the color of the stone. Now the color of the stone is also yellow. The aiming beam is the greenish in color. So it is sometimes not very friendly situation for the surgeon. Right. So many workshops I have seen that you can just to speed up the procedure, you can produce a fine popcorning kind of a thing in there and call it a day. But I don't want to do it because I just want to give 100% result to my patient. Patient should be happy at the end of the day because your surgery should be such that now I can take out this fragment, Tanuj. Yes, sir. So I will take out 2-3. I will go 2-3 pass into the ureter and take out the fragments, and then we can put a stent and come out. No problem. I think both the stones are dealt with. Yes. And even if I am in the upper calyx, can you see that the kidney is moving minimum? Yes. Because you have an excellent anesthetist. Yeah, because he has been giving anesthesia for almost now 27 years with me, and we have been doing RIRS for almost now 13 years, or maybe a little more. So he exactly knows what to do. So I don't have to even instruct him. Your life is made easy by his approach to the patient. And secondly, most important thing is that even Dr. Rahul, when he's flushing very gently so that we don't raise intrarenal pressure. Otherwise, intrarenal pressure will rise a lot, and then that can produce a lot of problems post-operatively, extravasation, intravasation, septicemia. And if you notice, now can you please focus here to Pani Dalaga? You can appreciate the backflow.
Yeah, we can see. You
can see the backflow?
Yes, sir. Very nice.
So this is also very, very important. That's what I was telling you when we started the procedure. You have to see the backflow. Normally, generally, this kind of a procedure for 2 stones does not take more than 30-35 minutes. Here we'll be finishing with explanation also. I think we should be in a position to finish in 1 hour time. So,
Can I
that's
take up some
okay.
questions from the
Kandar,
audience, sir?
Sorry?
yeah. Tanuj,
Can
go
I
ahead.
take up
Tanuj,
a
go
few
ahead.
questions from the audience?
Of course. Please tell me because I don't know what they want to know.
Yeah. So
Now,
one of the
give me
questions
basket.
is that how do you judge that a particular fragment can be extracted safely?
So it's it's more or less a judgment actually. But see, if you look at these fragments, these all fragments are sometimes difficult to catch also. They appear very big. I'll just show you, demonstrate you, and you'll know it. Now, this is a good fragment to catch.
Yes, sir.
This is approximately 3 mm in diameter. And if you have got a 3 mm fragment, it can come out easily through 10 French ureteral access sheet. So this 10-12 ureteral access sheet, maybe the little bit of this fragment may obstruct at the level of the tip of the ureteral access sheet. Let's see what happens.
Yes, sir.
But normally, I believe that it's not going to be a problem. So now we insert the basket.
Which basket are you using, sir?
Again, the same basket, right? What? Okay, so this is, Dr. Rahul has given me a flower tip basket just to demonstrate.
Okay.
It opens like a flower. Okay, and this is which company? What is this? Okay, this is 1.9 French basket, BioRed. Can you please go a little close? I normally use Boston Scientific basket, zero tip basket. Open the and let me make a disclosure that nothing is sponsored here. Okay.
Yes, sir.
This is completely unbiased opinion. So that's the reason I showed demonstrate each and every product so that people get an idea that what all is available.
Any tip on passing this basket and passing the previous basket? When you are passing the engage or the whatever the G-paw, and any tip on passing encircle?
There is not much tip. I'm grabbing the. Did you grab this one? Now what you can do is sometimes just keep it like this and now hold it. Hold it.
Okay.
Just say it is difficult. The reason is the stone is not very big. Now holding it.
I think
Okay?
for this fragment, yeah.
Okay, so we are holding it. Now you can check it. Just advance the tip like this.
Yes, sir.
Okay. And then this tip has to be like this. And now I just take it out. So the stone fragment, the bigger stone fragment is out. We'll send it for the. It's such a tiny fragment. I think you can show the fragment.
Can you?
Basket.
You can.
So once when you are inserting again, you just withdraw the tip in the scope and then you insert. Now again you are coming. Now one more point I wanted to just show you. Whenever access sheet is in position, what you see right now is the anterior wall of the ureter. So to insert the scope, what you have to do is that withdraw the ureteral access sheet little bit, advance your scope and deflect the tip down. Now we can go in like this. Okay.
Yes.
Yeah.
Again, I'm back into the kidney. Now you can appreciate all these small fragments. These are very tiny fragments. We'll try to clear one or two fragments.
Getting these small fragments would have been better with engage.
Yeah, of course. And this I just wanted to demonstrate this. That's the reason we did it. I understand that smaller fragments, even though some of the some stone fragments are stuck to the pillar. In that case, you may try to dislodge it, and if you cannot, then you cannot open this flower type of basket sometimes. So in that case, such a small stone, what you use is an engaged kind of a basket. Either it is engaged or it is a grass pit or it is a G-paw, whatever you want to use.
Is this basket a detachable basket, sir?
No, I don't think so.
Okay.
You have to, supposing if I'm stuck, then I think we may have to cut the basket.
Like all other routine baskets.
So this is you can appreciate that it's very difficult to, catch the fragments because these fragments are very, very tiny fragments. And they are certainly will come out on its own. So I don't have to spend this much of time for this. I'll try to grab one large fragment and just re-inspect again. Whenever you are finishing the procedure, it will always make sure that you re-inspect the and entire pelvic alyssal system so that no fragment has flown into some other calyx. So again, let me go into the lower calyx where it's clear. Can you see that? It's completely clear. Lower
Yes.
calyx.
Yes.
This calyx is also very clear. This is where we broke the stone. So these are the two fragments which we wanted to take
Yeah.
out. So that I'll take out now. Okay, hold it. Hold it open. Close, withdraw. So this procedure should happen, once you and your assistant know the procedure well, you can do it very quickly. You can very quickly enter into the kidney and you can do a complete clearance.
So there is a question from Dr. Ganesh Kamath.
Yes, please.
Yeah, so sir is asking, have you tried advancing the access sheath into pelvis and applying low power suction or using a syringe to suck the fragments out?
I normally put my ureteral access sheath in the upper ureter. I have hardly put my ureteral access sheath in the kidney because that will hamper the movement of my scope. But sometimes once you completely dust the stone, maybe you can advance your ureteral access sheath in the renal pelvis, which I don't want to do it. And for applying a suction, I have got my own reservation because I believe that when you apply suction, you sometimes cause trauma to the petech, the subcapillaries, and it can lead to a very nasty vision. And especially when you are using a digital scope, your vision, it is much magnified vision. So you get very bad vision. So I don't want to do that. Suction, I have not done it. I don't do it also. And I know that one of our colleague is applying suction, but I think he is doing great job. But I am not very much for it at the moment. I may change my opinion maybe in future with a lot of data available. What is your take on this, Tanush?
Sir, I also, as of now, I have my reservations for any sort of forced irrigation or suction from the PCS. There is some bleeding that happens, and but as you said, some people are doing and they're doing through the scope, so we have to see.
Scope, yes, that's a fantastic, but I have not. Sorry.
Yes, sir. We
So,
are still
Nanjappa, what is your belief? What do you think that we should do? Whether we should apply suction or we should not?
Yes.
Everybody has his own opinion, so I mean it's okay.
Yeah, though I don't have much of experience, but definitely suction is the future. So I think suction is going to come in now in a big way.
Can you appreciate the size of the stone which I have taken out? Can you?
Yes.
You can barely see. So it is not even 1 mm. I think I can. So I think we will.
Can you show the fluoro? Also,
can you please show the fluoro, please? Fluoro, you will not appreciate anything. पानी डालो, कुछ नहीं होगा. Fluoro में कुछ नहीं आएगा. Tanuj, it's such a small stone. I don't think you will get to know and get to see anything. When you are dealing with a very large stone, some people try to check it with the fluoro. Or yes, when you have any stone which is not located, I think I can use the fluoro. This is the one large piece I think I will take out. And I think probably that will be the last. Pani dalo. Hold it. Hold it. Grab.
What is the length of access sheets that you use, sir?
Grab.
Routinely.
Sorry?
That's a question from YouTube.
I normally use 35 centimeter in a female patient and 45 centimeter in a male patient. If the patient is very tall. Otherwise, 35 centimeter is a standard size I use, 35, 37, depending on the make.
Okay.
So if you have to have one access sheet conduct, you recommend just buy the 35 centimeter.
But don't have only one sheet. That is one of my recommendation. At least you should be having a good number of accessories available in your, even if you are, and especially it is true for when you are actually starting the procedure. This kind of RIRS learning, because you can be stuck up anytime, anywhere. So please do not compromise on the accessories. That is most important thing. These are very, very tiny fragments. Can you, we will leave it inside Bankaro. I'll just go last time in hand.
Please
Okay.
increase the size of endovision.
Sorry?
No, that's for the AV team. So please show the endovision.
Endovision. Show the endovision.
It's a request from the audience.
So you have to increase the size.
Yes.
Sorry, Tanuj, what did you say?
Yes, sir. Yes, sir. Yeah, we need to see larger picture of the endovision.
Larger. So we can make
Right
a
now we are
3x
seeing
magnification in that case. Can you please do 3x magnification? Normally we keep 2x magnification, but 3x with the 3x magnification, the vision may appear very big.
Yes, sir.
The vision may appear very big, but I think probably then the quality of the vision will slightly. Can you now appreciate this?
Yeah. Yes, sir.
Are you happy with this? Okay,
yeah.
so the last thing what you do is that we do a dye study now in majority of my patients. This is just to
why do you do now?
So we have checked all to completely check the pelvic alysis system, and then once it is done, we do a dye study just to check whether we have caused any intravagation or extravagation. Sometimes we don't. In such a case, we don't put. You can appreciate the fragments, small fragments, very tiny, right? And sometimes you don't put even the double chest stent. You may put a ureteric catheter and call it a day. So in that case, if there is an intravagation or extravagation, in that case, certainly I would like to put my double chest stent. Otherwise, this, so Rahul Panida, I'm just gently pushing the dye. You have to be very gentle whenever you are pushing the dye. You can see the dye going in, and now look at the vision. It is becoming turbid.
Please show the Siam view. Yeah.
Siam, batao.
Enlarge it, please. Enlarge the Siam view. Yeah. Okay.
Okay. So you can see the entire pelvic alysis system.
Oh, yes, sir.
Okay. Can you show again? Can you see it now, Tanuj?
Yes, sir. Very clear.
So there is no intravagation or extravagation. So your assistant also has done a good job.
Yes, sir.
And now we will be putting a stent under in a desired calyx. Wherever I want to put my the guide wire, I can place it. So can you give me the guide wire, please?
Kanda, after every procedure, you would recommend this, or if it's a very clean cut procedure as you have just done?
Normally, see, it is not mandatory. It is not mandatory, but I normally do it because of the safety issue, which I am concerned. That's the reason I am doing it. Otherwise, it's not necessary. You don't have to do it.
How many days would you keep this stent and?
This patient, I think probably 7 days, more than 7 days. I don't want to put the stent inside. Even if I put a ureteric catheter, it's okay for this patient. But supposing if I want to put a stent now, another important thing, whenever you are now, give me the Siam, please. Give me the Siam, please. Single shot. Okay. So now you can see that I am withdrawing my ureteral access sheath also while I am taking out my scope. Take out the ureteral access sheath. This job is just to assess that we have caused any trauma to the ureter or not. Can you see that?
Yes, sir.
Yeah.
Yeah. So then, because there is no water flow going in, the vision is slightly bad. But I think this is perfectly okay for me. Just take out. So you have to take out the ureteral access sheath under vision. If you have got a safety wire, your job is easy. Here, what I have done is that I have kept the guide wire through the ureteroscope while taking out the ureteral access sheath. So my ureteral access sheath is out. And we'll put a double chest stent. Give me the stent. So this is 10:25. We are just 5 minutes before our desired time. So we'll put a 6 French 24 centimeter stent. It can be any company. It's not very choosy about the.
Yes, sir.
Okay. So I think we are done with this. Any question finally, if you have?
We still have some time, sir.
Yeah, please tell me. And Dr. Saeed has joined us?
Yeah, he's already there online.
So there is a question from Dr. Narendra Reddy. If basket is stuck in, what do you do?
Okay. So I hope it doesn't happen to you. But if happens, then in that case, I've got 2-3 tricks. Like I normally select First is the selection, that you should not try to bite more than one. You should not try to bite more than you can chew. So don't hold a very large size of stone. That is one. Understand the anatomy of the pelvic alical system. That is second. The third important thing is that then repeatedly open and close the basket and thrust it slightly gently against the mucosa. So, and tell your assistant to flush the fluid. So that might change the axis of the stone you are holding, and then probably the stone will drop into the calyx. And the last thing, if it doesn't happen, in spite of repeated trial, in that case, you might have to disconnect. I'll just show you what you can do. ऊपर बताओ ना, बताओ, ठीक है, बताओ, बताओ. Okay, just take it out. So my stent is also in position. So in that case, what you have to do is, if it is not disconnectable basket, in that case, you can cut the basket here.
Everything, please enlarge the surface view.
Yeah, please. Now I think under vision
Surface
need not
view,
be,
please.
it's not necessary.
No, yeah.
Okay, so here you can, or this basket, let me take this basket. So supposing if I grab the stone and I'm unable to release it, in that case, what you can do is that you can cut the basket here. Okay, so the handle is off, and then this part stays in the patient's body. Take out the entire assembly and then go by the side of this wire into the kidney, and then try to lace the stone, or you can lace even the wire of the basket. You can sacrifice the basket. As such, your basket is gone. So this is how you can disengage that. Don't try to pull it. You know, that is very, very bad. Otherwise, you will avulse the ureter. That's a bad complication. We don't want any complication, because RIRS, comparatively to my mind, is a very patient as well as surgeons friendly treatment, and you can produce excellent result if you select the case properly, perform the procedure very well, and you have got adequate accessories as well as the scopes. I think that is very, very important. Do not compromise on any accessory. That is what I want to say. Thank you, Tanuj. I think 10:27, and you've got any 2-3 minutes we have got to any question. Last question you can ask, tell me.
So if you see some mucosal injury while withdrawing the sheath, what extra do you, if as a beginner I'm asking, if I see some mucosal injury or some,
and you can see the just Tanuj, see that normally after every RIRS we try to see this kind of color. Okay, so if you want to compete, I would not say compete, but it is a complementary to PCNL or mini PCNL. So you should be in a position to produce equally good result what we produce with the PCNL and mini PCNL. So that is my attempt always. So your urine out color should be like this. And this catheter, when I conducted a workshop in Nepal, they don't put even post-operative catheter, and they just simply discharge the patient in the evening. So that is what also is practiced. But I normally keep stent as well as catheter for 24 hours. I will discharge this patient tomorrow morning, and then patient is back to the work by tomorrow evening, because we have not put any cut and no. And antibiotic we normally we give only one day. So today patient was admitted in my hospital. So morning one shot was given, another shot will be given today evening, and tomorrow morning when we discharge the patient, the third shot will be given, or patient may be put on a oral antibiotic. We normally prefer ciprofloxacin or ofloxacin with the flavospas tablet, and we also give alpha blocker to the patient, so that irritative urinary symptoms can be minimized. I'm not very sure, but it can be minimized. So that's the way we normally do RIRS. In the next case, I think we'll show you how to insert the ureteral access sheath, and we'll use a thulium laser fiber, so that I think people can appreciate the difference between these two technology. And the thulium fiber laser, I will talk a little more about it, because we'll be discussing for 1 hour, and it's a large stone. It's a 2 centimeter size stone. So I think probably it will be a treat to watch that stone.
Sir, anything?
Excellent demonstration. Yeah, excellent. I think we have a lot of time, still a lot of questions, but I think in the second case, we'll take it up. So wonderful demonstration, Gandharv. It was a beautifully demonstrated. So I think now we'll go on for our presentation, and then we'll come back to you. Okay.
Thank you so much. Thank you so much. I appreciate your help. Thank you.
I think that was a lovely demonstration. And now we have Saeed online here.
Good morning, everyone.
Good morning, Saeed. Good morning. So let me just introduce you. Dr. Saeed bin Hamari is one of your very well-known endourologists, and he's the chairman of the Saudi Endourological Minimally Invasive Surgery and urolithiasis group at the Saudi Urology Association. And he has done his endourology fellowship at none other than with Dr. Olivia Traxa. And we all know Said for his, unique way of presentation and the way he puts up his slides. He's not only a skilled endourologist, but he has a lovely skill of presentation. So welcome, Said, and we are here to listen to you today on anomalous kidneys and how do we tackle this procedure in those cases.
Thank you.
Over to you.
Thank you. I would like to share my screen, right? So,
Navneet, please make him co-host.
He's a co-host, sir.
So I can show my screen.
Please try to share.
Yeah.
We can see your screen.
Thank you very much, and good morning, everyone. It's too early in Saudi Arabia now. It's almost 8 o'clock. I'm so thrilled and privileged, honored to be with my Indian friends. And thanks for the Urological Society of India for inviting me again and again. So my friend kind of asked me to talk about the retrograde renal surgeries in anomalies of the kidney. And this is a very specific subject because of the nature of these anomalies. I'll start with my declaration that I work with certain companies for education and training, and all videos you're gonna see and images are in my hospital. Let's start with the beginning of the limits of ESWL, as De La Rosette described in the European journal, that the recognition of ESW limitation improvement and the improvement ESWL efficacy had resulted in minimization of possible complication. So we have to know the limits of the ESWL, and one of the high standard studies is the systemic review done by the group of Somani, when they said that the uteroscopy is a very challenging in anomalies of the kidney technically. However, these advances in laser and uteral access sheath and everything have improved the results. So I will take you to a virtual tour, what we can do with the flexible uteroscopy in anomalies of the kidney. We will talk about the horseshoe kidney, which is the famous anomalies, ectopic pelvic kidney, cross-ectopia, renal diverticulum, polycystic kidney, medullary sponge kidney disease, ectasia, and nephrocalcinosis, and double ureters, of course. The starting, we have to admit that the laser pushed us to the maximum because of the disfragmentation, turning the stone to the dust, and with the thorium now we came to the micromillimeter of the small particles. And as you can see, in 1997, it's almost 20 years since they described the laser, and it fragments all the type of the stones. Let's go for the horseshoe kidney. For the beginning, that one of the largest series in the world, the SWL, showed a 66% of the success rate. Another study by the Andrew, where he described the 63%. But if you dig into that article, the stone-free rate is about 29%, which is almost a third of your patients in the horseshoe kidney will be stone-free in one out of three. In flexible uteroscope, this is a Traxa group and us, when we published 88% almost success rate in such anomalous and difficult situation. And the trick here that the horseshoe kidney with a high inserted ureters necessitate to have whether a new reusable one, because you need the deflection through the ureter, or a disposable one if you have certain of difficulties because of the deflection toward the isthmus. This is a stone in 2 centimeter bilateral horseshoe kidney. You can see with the 2 stages, you access the kidneys, and then you turn that stone to dust or small fragments, and then afterwards you will end up with the magnificent result. As you can see, this is the pre-op stones bilateral 2 centimeters, and the post-op showed a stone-free. It's true that stone composition may play a critical role in dusting, then alkalinization or this, but it showed that how flexible can access these kind of anomalous easily and fragmented these stone with no difficulties. If you go with the ectopic pelvic kidney, you can see that this is a Turkish group where they say the flexible ureteroscope safe, effective, minimal invasive for pelvic ectopic kidney. They showed about 84% in 22 cases, which is the largest series in the world. 84% of the success rate. Our group showed 88%, which is a very, very high success rate in such anomalies. You can see here that different scope. This is the before the when the second generation P5 and Flex X2, that the both pelvic kidney had, this patient has a 4 centimeter stone, 1 centimeter each, and he had 2 stages of the stone. Then eventually he's a stone free. That was true that at that time the Flex X2 showed superior act rather than the P5. This is a 2.7 accessed by Pusen, and this is the advantage of a disposable ureteroscope, where you are not afraid to go for a very active deflection and laser the stone without a fear. This gave us the space and pushed us to maximum limit of having the retrograde renal surgeries, and not only in anomalous kidneys, even in a normal kidney. This is a large burden stone, 2.7, finished in 2 stages. And the point here that the patient should understand the stage therapy in this situation. Not only a pelvic kidney, it's a pelvic kidney in a 4-year-old boy. Whether the retrograde renal surgery, the development of a huge accessories. Look, this is a Pusen 7.5. So it's a pelvic kidney and a small child. You access a 1 centimeter stone easily without a preparation in your ureter or with the pre-stenting. So true that in the pediatric group, the pre-stenting showed a superior in lower complication and a higher success rate. The cross-ectopia is a very rare case, and these are very accessible to the ureteroscopy, especially with the thin diameter and the shaft. Let's go for the renal diverticulum. This is a beautiful study from Borak when he showed the SWL at 21%, PCNL 83%. When we published in English and French both, we reached about 81% by the flexible ureteroscope. So the flexible ureteroscope with the laser is approximately same as the PCNL with a lower risk of complication. And one of the tricks here that you have to identify the neck of the diverticulum. And by that, Patel in 1995 and improved by Olivier Traxler 2003, they developed the what we call it a blue test. You inject the intracalyceal system by methylene blue and contrast, and you wait until you see that small diverticulum. Flexible ureteroscope is a very successful treatment for those with the short neck and very short, narrow neck. And you could see easily, you just cut until you introduce your ureteroscope inside the cavities without any difficulties. And you might and you could see here, this is the verticulum. You inject with the contrast and the test blue or blue test, and then you wait, then you access that neck and you incise it and you get inside the diverticulum. But the main problems with the incision that people will say that neck will close. This is a 6-week later post incision. You can see it's a widely opened, and we are so early to get rid of these dust from inside. Just ask your patient to mobilize postural therapy. And one of my colleague, he's introducing the balloon dilatation that I don't see in efficiency rather than the laser. You just excise it well and leave it. And we remember, we are treating the symptomatic diverticulum. I'm talking about pain, hematuria, or recurrent infection. In certain situation that you will tell yourself, this is easy for upper pole or mid pole. What about the lower pole? So I will just show you, this is a patient, we're having a renal stones, renal pelvic stone, and a lower pole anterior, which is amenable to the laparoscopic, but the patient agreed. You can see this is the diverticular stone, 2 centimeter anterior aspect. The patient agreed to go for at least 3 stages or 2 stages minimum, where we able to attack this stone in the calyceal system and then approach to the diverticulum in the lower axis. You can see this is a flex XC, a very nice angulation, very nice deflection. You incise it, you take your time not to exceed 90 minutes. And eventually, by the last video you see in the right hand, patient is completely stone free. Polycystic kidney, we know that the polycystic kidney through the PCNL is very challenging. But however, in most of these cases, the patient presented with a very soft stone. So you could see that the advantage of a flexible ureteroscope is swimming inside these, the calyceal and small infundibulum, because of the cyst that compress certain infundibulum, and easily you can swim and access any calyceal calyx you want in these kind of kidneys. The PCNL is very challenging, as well. I will show you in this slide. This is one of the largest series in the world, 221 cases that showed the superiority of the flexible ureteroscope, 73% to 100% success rate compared to 69 for SWL, and from 45% to 100% PCNL. But on the other hand, you look for the complication. SWL had more rate of complication rather than the ureteroscopy, 27%. And if you look for the PCNL, you have a 100% in certain cases. So the flexible ureteroscope in a polycystic kidney has a more success rate and less complication. And one of the that you might ask yourself, why this patient has his double SWL failed many times. We have to think about these cases. We call it ectasia or nephrocalcinosis, or covered by the mucosa. You just get inside the mucosa and get rid of that stone by disintegration laser. And here is the advantage of laser and the retrograde intrarenal surgeries, where you can do these cases in a short term. It's like 45 minutes and you discharge the patient within 2 to 4 hours. Rather than that, you can see those patients complaining of hematuria, pain, and you will be surprised. You will be surprised to see those kind of a stone hidden into the calyx. It couldn't be randal plaque because it's completely covered by the mucosa. So the laser comes to incise the tissue and then hit the stone and fragment it, and your patient will be happy and you are happy. One of the number 7 is the medullary sponge kidney disease. The Kashi is Roberto, and Vinceni is Rishi. Both Italian discovered this disease, where that stone inside which is a congenital malformation inside the ducts of this is one of the beautiful images that I took. The patient was symptomatic like 10 times into the emergency because they expelled the stone into the ureters. And this kind of stone could be any composition. This kind of stone could be any size, the size between 4 to 8 millimeter maximum. And the advantage of ESWL is this: if the pain, it doesn't treat the stone, it doesn't incise these ducts, but the flexible ureteroscope helps you to free that patient for almost 2 to 3 years without coming to the emergency. As you can see here, we incise that tissues. Some people will say, okay, maybe we distract the papilla. I don't see any parenchyma or tissue here. It's just like pockets of a stone. You just incise it. And I remember this patient was absent of follow-up for 3 years, and she was doing fine. I called her. So you could do many things with the retrograde intrarenal surgeries. The technology is huge. The advances is super. And one of the cases as well, I would just heard some news about some discussion about the thin scope. Here is the thin scope is preferable, whereas the Flex 6.2 or even the OTU, this 8.7 could access these small diameters and thin ureters, especially the double ureters. I'm talking about double, so not the double system. So the flexible ureteroscope with the sizes, you can see the Flex 6C was in the double ureter, dilated, pre-stented, but Flex 6.2 was needed in certain ureters, as you could see here in the third video in the right hand. Easy access to the ureter. The Pusen as well, if you have a double ureter prepared, there is no problem. But in these cases, you have to think about the size, not the image. Thank you very much.
That was a wonderful presentation, Saeed, as usual. Can you just tell me now, every challenging case which you have, do you use a disposable scope or do you use a reusable scope?
Well, since the introduction of disposable ureteroscope, I think I shifted completely to the disposable for the congenital, for difficult cases for two reasons. The first reason is that the reusable, even with the refurbishment, even with the deflection, the deflection will be less in the 10th operation or 11th operation. In these challenging cases, you need a new, whether you specify one of your reusable scope for those cases or you take the disposable.
At your place over there in Saudi, do you all have any restrictions with reusing a disposable scope, or?
There is nothing called restriction. It's in the law that is restricted, but I know in the most of the hospital, they do recycle these disposables.
So do you all also recycle it and you all use it, or no? Not done
in the government hospital, you are not allowed to recycle it. But if you look for example, the endoscope from Bayreuth, it's a multi-use, it's like 16. So if you think about reusable or disposable or the specific numbers of reusable, I think it depends, but there is no law. I think in India there is no law. There's people, they recycle it. But when I was in Africa and most area of Saudi Arabia, they do recycle it and they don't have any problem.
Okay, so but what we need to have is a policy in the hospital that this is how we are using the single-use device. That is, it's not mandatory, but it is required at least by the accreditation systems in India.
True. I think, as you, Tanuj, you said that the policy of the hospital is more important than the policy of the health administration or the government, because you look inside the room and you control it by a small area of surgeons and doctors.
Yeah. One thing I wanted to ask you is, in all these anomalous kidneys, in specific situations like ectopic, pelvic ectopic kidneys or horseshoe kidneys, what length access sheet do you like to use, and where exactly do you like to keep the access sheet?
That's a very nice question, because in the pelvic kidney, I order always a specific access sheet. The only company that do an access sheet less than 20 centimeter is Cook. I heard some maybe Vikram was presenting a 20 centimeter. I have a 13 centimeter. So in the pediatric or the pelvic kidney, I use 13 or 20, because if I use a 35, which is not necessary, I will have a very difficult access to manipulate the flexible ureteroscope. So I prefer the pelvic kidney to be 13 or 20 from Cook. This is the only company that can do this, and you have to order it 2 months before. And the one thing that if you cannot use an access sheet in pelvic kidney, use the smallest scope like Pusen 7.5, endoscope 7.5, but you have to put an NG tube or something to empty the bladder because of the return fluid. And preferably, you have to prepare the ureter.
By preparing, you mean we should pre-stent?
With a stent. I believe that these anomalies of the kidney, that if you need a more success rate and high, less complication, I think preparation of the ureters are preferable.
do you have any tips for the particular infundibular stones?
I don't think there is.
Infundibular calyx.
You mean the stenosis that
I mean the isthmus. Stone in the calyx is the isthmus.
There is no I think if you prepare the ureter will be mobilized and you will have more accessible with the deflection. Or you could do something, you push your scope, and one of the characteristic and specification of this scope, the double deflection. So you can push your scope and make it with the second deflection into the isthmus. But I don't think there is something difficult for the flexible scope with the trained endourologist.
And as you mentioned, you would prefer disposable scope in all such cases.
True.
Saeed, in certain cases, what you just mentioned about going into the isthmus, it's a difficult turn. Do you switch over sometimes from a disposable scope to a fiber optic scope because of the ease of deflection at the tip? The last part, if we couldn't go in, do you do that sometimes nowadays, or you feel that our
true? But you know, Flex X2 was my saver until I have the Pusen 7.5. We don't have the. I heard a lot about the Biorad endoscope, the smallest shaft, but I think the fibroscope will stay there in the poor countries because it's very cheap. There is no camera, there is no chip. But with the disposable and some countries recycling, I think the reusable scope will be obsolete from the market. I don't know.
Yeah, you're right on that point. What is your take on suction with ureteroscopy now? So
Yeah.
How do you use suction? Do you have experience with suction?
This is the big debate because I was in a meeting a month ago. So the people now, they created that scope with the suction inside it. It's like the bronchoscope. But the problem when you are doing a retrograde intervenous surgeries, you have to keep a certain pressure for better vision and better manipulation. It's not like the PCNL where you have an open system. You can have, the pressure is not important. If you put the suction, you will have a collapse system. If you have a collapse system, you cannot see more and you will bleed more. So the balance between the suction and irrigation should be very, very wise. Otherwise, you cannot achieve these things. I think the suction is too early, and it depends on one thing, my friend. It depends on how dusting you do it, because if you do with a 30 watt or high energy and low frequency and end of the small big fragments, it will be suctioned inside the access sheet and might damage the ureteroscope because of the two French between the access sheet and your scope, especially if you're using Flex 6C. Or it might be aspirated by the working channel, which is very small, and it might damage the inside the working channel, and you will spend a lot of time. I think it's too early until we develop. The Tholium came to find that solution, but it's too early to think about the suction. I think he's very successful in the PCNL with the clear Petra as showed by the SAI group. But in the flexible ureteroscope, I think the wise irrigation, dusting is the key now. The suction will come later.
Do you feel TFL is a better dusting tool than Holmium?
My experience, I believe I was discussing with Olivier. Olivier is a very, very big fan of the Tholium, but I think the Tholium is a very nice tool and I believe that it will dust 20 to 30%. It will save your time from 10 to 20%. This is for the time being. The bottom line that we have a great expectation about the Tholium. We need it to be on the ground for whole the country, and it will take 10 years to prove itself. It's not like a 1 year or 2 years.
Right. There's a question from the audience. In case of infundibulotomy, if needed to enter a calyx with narrow infundibulum, is there a particular direction in which you have to cut?
That's a difficult question, because in the diverticulum people, they ask us where do you incise. I prefer to incise towards the what do you call it, the convex or the papilla, because you avoid the vessels. Some vessels could be crossing around the infundibulum, and I had one case where we inside the infundibulum and we hit that artery, which goes the narrow of infundibulum, and that patient was shifted to the ICU then for embolization. So you have to be careful incising the infundibulum. My advice is just to incise little step by step until you introduce your your scope. If you have the Flex 6.2 or Flex 6C is much better. If you have a big scope, so you have to incise more.
Saeed, do you have any, any limit for your stone size in RIRS, especially when you have talked about all these anomalous kidney, stones in these situations, or in a normal kidney? Do you limit the size of your stone which you select?
I like to see two factors, which is very important for me. The patient himself. The patient has to be convinced in the stage therapy, first of all. Second thing is the stone composition. Stone composition is very important. We see people that I do 4 centimeter, 5 centimeter, but should be uric acid, should be very fragile, should be Hounsfield less than 700 or 600. That will be easy for dusting and doing. If you are talking about cysteine or calcium oxalate and you hit at 2 centimeter, you will end by 2-3 stages. This is what in a good hands, you might end more than 18 millimeter. In some literature, statistically, we're talking about 2 stages. In the guideline European 1.5 and down, you go for flexibility scope. But for the large version of the stone, you have to be very careful, because one of the studies that we showed that the complication of the retrograde surgery increase with the stone size. The stone size is the independent factor of complication for retrograde surgeries. We don't want to push all juniors to flexible uteroscope. We need to train them. It's a very safe, it's a low morbid, but it's not sometimes the best option for the patient.
So in the same, continuing the same thing, how much time do you limit your procedure to? Do you have a limit for your time? How do you, if you want to stage it, how do you time your procedure?
If it's a prepared ureter, I'm happy with the pressure and irrigation. I will spend from 90 to 100 minutes. If it's a virgin ureter and I'm not happy, it's intraoperative thing, I will limit it to 60 minutes. So bottom line, we will say that retrograde surgery is between 60 to 90 minutes, maximum 100 minutes, and you could achieve things. The thing that people, they might waste the time accessing the bladder, the ureter. So if you think about trained urologists, some of the urologists might go to the kidney within 5 seconds. Some people, they spend 10 minutes to see the orifice. So talking about the time, is it the time of the ureter access sheet? That's why I taught, I believe Traxler taught me that the timing is the time when you introduce your access sheet. It's not the time before or after. So if you say 60 minutes, we say it from we are seeing the stone inside the kidney.
When there is a lot of dust, sorry, Tanuj, you want to take it?
No, please go ahead, sir. I'll ask the next one.
I would like to know, Saeed, if there's a lot of dust, nowadays with the thulium fiber, you also must be using it. And if there's a lot of dust, now how do you manage your vision? How do you know which fragment is left inside the kidney, and how do you manage that? Any tips on that?
That's a very big problem, but I solve it by 2 things. That you have to have a pulsatile pressure. It's not like a continuous pressure. I use a Traxoflow or a syringe from Olympus or SAPS from Boston, that it will clear these dust. And one of the tricks I use is to inject a contrast every 20 minutes. That contrast will collect these dust together and will improve the vision. And so it's true that the thulium gives you more dust, but I think you can beat it with tips and tricks.
If I'm not wrong, you said you introduce contrast every 20 minutes?
No, every 20 minutes I introduce contrast just to collect these dusts. If you spend 60 minutes dusting the stone and you see that you just inject, the contrast will improve your vision and will clear these small particles together with the irrigation. Try it, you will be more than happy to see it.
Yeah, even if there's a little bit of bleeding, the contrast gets the vision clear. That's the wonderful trick.
Exactly.
Yeah, that's the trick we should do. Yeah. That's why I took you on that.
I don't use an X-ray anymore. I was seeing some Chinese. I was so impressed. So now people, they ask me, why do you need a contrast if you don't have an X-ray? It's the contrast is just to clear the vision.
Do you recommend doing?
Sorry, Dr. Ravi, whenever you're ready with the case, please let us know.
Yeah, do you recommend that we should not use fluoro at all?
I think if you are an endourologist and doing more than 300 procedures per year, you have to think about it. That the second line of cancer. I have a friend in Europe who has a leukemia, and I was so cautious and anxious about him. So I told myself, how many cases? If you're doing 200, 250 cases, in that range, you have to limit the X-ray. Otherwise, we are so exposed to X-ray. I've seen people doing PCNL with the fluoroscopy. I do ultrasound guided, and they spend 6 minutes to 20 minutes exposure. The retrograde renal surgery, if you don't have a good technician, he will expose you more. And I believe in a certain endourologist who is so active, he should avoid the X-rays. But I don't recommend it. I don't recommend it for the junior. I think he should exceed certain number of procedures that it should be in his logbook until he became an expert that he accessed the kidney with no problem.
So even putting an access sheet, do you do it without the fluoro, or do you always use a fluoro there?
If you are a beginner and you don't junior, within 3 to 5 years experience, use an X-ray. If you you are an expert, so I use the feeling, so I feel it now. The vision is the X-ray is not very important for with the experience. You know, some people, they do trokers without inflating the abdomen, so it comes with experience. We don't teach the junior this one, but we keep it for ourselves to talk about it.
What guide wire do you prefer to insert the access sheet?
I like the stiff hydrophilic guide wires because of the slippery effect, and the stiff because of the stand. And some of the American and European, they like the sensor or the solo from Bard or Rio from Rocamed because of the stiffness. The problem with the hydrophilic is there is no hydrophilic coating, so you might have difficulty to slide it inside the kidney. The hydrophilic stiff guide wire from Tiramo is my preferred guide wire.
Do you calibrate your ureters before going in, before opening your access sheet, or you just go in with a straight away access sheet? Do you see your ureter, you calibrate your ureter?
Olivier told me that you have to calibrate it with 7 French. One of the tricks, you put a 7 French ureteric catheter. If that goes easily without a friction, it will be good for 10-12 French. You know, then the trend now is 10-12 French. So the success rate of accessing the kidney came to 7%. So one of the tricks, take a 7 French ureteric catheter and calibrate it instead of opening a ureteric access sheet. And if you say, no, doctor, I have tried it and it went fine, it might go for like 1/5 time, but this is one of the trick. I calibrate it.
So you don't do a visual calibration, you go with your semi-rigid scope, or you never go with a semi-rigid scope of the ureter?
I don't use a semi-rigid anymore for the flexibility scope, unless if I have a stage therapy with a cysteine or something that I suspected some of the stone in the ureter. So if I just feel it, if you have an experience of putting the access sheet and feel something like scratching, so you feel that stone down. If you are sure that there is no stone down, you don't need that semi-rigid. But it's a recommended for junior again to see how the semi-rigid and the ureter and sequential dilation at the beginning.
You had a situation where your access sheet didn't go in, and then you had to backload your scope. So you opened up your access sheet and you have to backload your scope. Any tricks on that?
You mean if I put the access sheet and go with the scope?
No, you open your access sheet and the access sheet doesn't go in the ureter.
So I back, if it's a virgin ureter, I have to backload it. If it's a prepared ureter, we go easily into the ureter and the ureter will be fine, especially with the smaller scopes.
How many percentage of cases do you nowadays pre-stent? Do you pre-stent any case, or you do everything primarily?
Before, when I used to be trained, you know, we have to. I was so surprised when one of your Indian colleagues said the Indian ureters are very thin. You know, I don't believe
they are very thin.
Yes. And that's the sense. Saudi Arabia, we have a dehydration, Asians, ureters. But if you go to Germany, I was in many centers in Germany, they use an access sheet 14, 16. And even though I've seen 16, 18 French, German, they drink a lot of beer. And the French, they drink a lot of water. And in Middle East or Asia, we are so dehydrated that our ureters are so thin. So I think we have a high rate of failure of ureters. So the pre-stenting in our culture or our area is recommended rather than those European. Then it depends on something that if you are a referred endourologist, you will have cases of the double descent, so you don't feel it. But if you have those virgin ureters, you will suffer. If you ask those experts in endourology, he will say, since when you saw a virgin ureter? He will say since long time, because all of his cases are referred from certain centers.
So definitely that is, I think Saeed recommends drinking beer to enlarge to dilate your ureters. So that was a wonderful presentation and discussion, Saeed. I think now we are nearing 11 o'clock and we should get back to Kandar to his OR. And it was a lovely discussion. Always pleasure to have you with us here.
Thank you very much, my friend. Thank you very much. Thank you.
Thank you.
Thank you.
So we get back to, I think, is Ravi ready with this thing? Kandar, is he there online?
I think Dr. Ravi.
Yeah, there he is.
Yes. Are the slide visible?
Yeah, we can see the.
Okay. So excellent discussion by Dr. Saeed bin Hamari and absolutely fantastic discussion going on with Dr. Tanuj sir, Dr. Nanjappa sir and everybody. And we are all having good participants, almost more than 170 participants online at this time. So the second case is a 62-year female patient who is presented with left flank pain on and off for the past 4 months with occasional burning micturition. Her lab parameters are within normal limits. Her urine culture was positive and was sensitive to cefoperazone sulbactam, for she was given injectable antibiotics, and repeat urine culture has been sterile. She has a 16 mm pelvic calculus with Hounsfield of more than 1400 with pyelonephritic fat stranding and UTI, for which she was pre-stented on the left side. So today we are planning for the left RIRS. Over to you, Kandap sir.
Again.
Hi, Kandar.
Hi, Dr. Nanjappa. Thank you, Dr. Saeed, for a wonderful talk and honoring our invitation. We are obliged. And I think we start with the second case. Dr. Ravi has already given you information necessary. This patient, we are going to use a thulium fiber laser, which is completely a different technology than holmium laser technology. The first case we used holmium laser. So this is 60 watt thulium fiber laser by Quanta. There is another company, IPG, also has the same product. And so in India and Russia, IPG is dealing, and outside India and Russia, in the Europe and in US, Olympus is dealing with this IPG machine, which is Solitaire. Here we have got a Quanta machine, and the wavelength of this thulium fiber laser is 1940 as compared to 2100 of the holmium fiber holmium laser. This machine does not have a typical holmium cavity. It has got a long wire which is about 10 to 30 meter in length with the internal diameter of 10 micron, and this internal diameter has got thulium bead which are pumped by multiple diodes, and these diodes will initiate the thulium energy within that laser fiber. So because the internal diameter is very narrow, you can connect a very small caliber laser fiber to this machine. You can, in future, there is a possibility that probably you will be in a position to connect a 50 micron or 100 micron laser fiber. Right now, we'll be using a 200 micron fiber, which is available. So the important feature of this thulium fiber laser machine is that the water absorption of thulium fiber energy is 4 times more than the holmium energy. So the machine the energy will be absorbed very fast in the water, so that you have to be very close to the stone to be effective. And the vapor bubbles which are generated are very small in size. And you have a possibility to manipulate the laser energy, that is a pulse energy, from 0.025 joule to 6 joules as compared to the regular holmium laser. Secondly, the frequency can go up to 2000. Normally, we do not use 2000 frequency, but you can go up to 2000. We normally use 100 to 200 with the thulium fiber laser, and which will speed up the procedure. So stone dusting is much finer, better, and the stone fragment size is, the dust size is almost 250 micron in size, much quicker, 4 times quicker than the holmium laser, and minimum retropulsion. So these are the feature of this thulium fiber laser. So maybe in future this will be a game changer. There are some problems with this machine also that I will discuss with you while we perform the case. So now we are ready with the case. Can you please come here?
So can I ask you a question regarding the laser?
Sorry?
Can I ask you a question regarding this laser?
Yeah, Tanuj, you are not much audible to me. Can I
ask you a question regarding the laser, sir? Just one question. Does this also come in 30 watt and 60 watt like the IPG laser?
I can't hear, Tanuj.
He has just asked you, does this laser come in a 30 and a 60 watt, or just it comes in 60 watts?
This machine, this company, I think is coming out only with the one version, that is 60 watt. I think probably IPG has both the versions because it can be used both for stone and the prostate. But this company has got only one version. Okay. So in this patient, we have placed the guide wire. This patient was stented 3 days back only. So we don't know whether we will be in a position to put a ureteral access sheet of 11-13 size. I'll try. This is a new ureteral access sheet, Boston Scientific's Navigator. It's lovely sheet. I really like this. Can you please put it inside? Because the patient was not stented or pre-stented just before 3 days, I do not know about the caliber of the ureter. Normally, when we do
you want to do a semi-rigid?
So we normally do a semi-rigid.
Semi-rigid?
Yes, so when we perform RIRS, the first step is to do a semi-rigid ureteroscopy with a 4.5 French ureteroscope. That's my preference. You can do 6 French also, and then you can assess the ureteric orifice, the entire length of the ureter, as well as if there are some surprise findings in the ureter like a stone or a tumor. So these are the 3 purposes, and also it will dilate the ureter little more. So these are the 4 purposes you saw when you do a semi-rigid ureteroscopy. So that is my first step. In this patient, we have already done it, but just to save time, because we have got only 1 hour to finish the procedure, so we discuss. So we have already placed the guide wire. The ureter is okay, not very big. Let us see, but it's not holding my scope, so no problem. I'm not going to force my ureteral access sheet inside. 11-13 I am putting because I want to demonstrate biorate scope, endoscope, as well as the lithoview in this, so that you can compare the vision. Okay. So now this is how you backload your ureteral access sheet. You can see it. I'm holding it here. Can you see it here?
Yes.
Tanuj?
Yes, we can see that.
Okay, and yes. Then always take a help of a CM. I normally avoid radiation with my tactile feed. Only I go in the ureter. But for the sake of demonstration, I will do it. Otherwise, normally with my tactile feedback, I go in, or we can take only one single shot CM fluoro. So I'm putting my ureteral access sheet inside. Can you please look at this?
Yes,
so I'm gently putting my ureteral access sheet inside with the rotatory movement, very gently. Can you please show? Can you see the CM now?
No, please show CM.
No, we can't see the CM.
Yeah, we can. Please. Yeah, so the access sheet has gone in. And I'm not putting. You can even use only one thumb. You can see here. I'm not pushing. I'm holding my guide wire here, and I'm just slightly gliding this. You can see this. This has gone in.
Yes.
So I'm not pushing even the slightest. My ureteral access sheet has gone in the almost in the kidney. You can see the stone, big stone, and the ureteral access sheet and the guide wire. Can you see that in the CM image?
Yes, we can see.
What is the length of this Navigator HD?
This is 35 centimeter ureteral access sheet. Because the patient is a female patient, the ureter was very friendly to me, and it's all your good wishes that I could go in without any problem in this patient.
All your skill also, Kanda.
Thank you so much. So now in this patient, because my ureteral access sheet is almost in the renal pelvis, I take out this guide wire and we can insert the ureteroscope straight away, like you said in the morning. So first I will try to use Boston's lithoview. This is 9.5 French.
One small question over there. When you put the ureteral access sheet, you have gone right into the pelvis, almost into the upper calyx. Now, do you reposition your ureteral access sheet, or you
yes, I will. Can you? What is this color? No, I will see here. But this is what you will be seen outside, right? Okay, just can you please connect water, please? So sorry, you were asking me some question, Nanjappa?
Yeah, because
Yeah,
your
I'll
ureter access
reposition.
sheet was 2N.
Yes, I agree with you. We will reposition it very in a minute, because
So do
if the
you do
patient has
this
also
under
very short
fluoro or do
stature.
you this?
Sorry.
Do they do this under fluoro or do you do this endoscopically?
Normally, you should do it under fluoro. You should not. I don't want to advance my ureteral access sheet beyond UPJ, because UPJ is the most unsupported part, and there is a possibility of the UPJ injury also sometimes if you have to push the ureteral access sheet. But here you could see that I could glide my ureteral access sheet very easily with only one just push up my little my thumb, and that's the reason I did it. And otherwise, normally, if you are taking the help of a CM, I think that is better. Pani Rano, please show the vision, please. So I'm going in now. And now I'm replacing my ureteral access sheet. It is, you can see that I'm in the kidney.
Yes.
Are you having, this is a stone, which looks like a very hard stone. Can you see that?
Yes, we can see that very clearly.
Are you getting a good vision? Pani.
Yeah, can you tell us what are those 5 dots on the side of the screen which you see? The
Okay, that is these 5 dots are, I think, basically for the brightness. The 2 dots appear green, right? Yeah, so I think probably it is for the brightness. This is a dedicated monitor by Boston Scientific. Can you please show this monitor? You have to have this monitor, this system also when you buy a scope. So you can see now
this monitor be connected to a Can
directly
this monitor be connected to our monitor?
Yeah, it is connected. You can
monitor?
connect it. You can connect it with my monitor also, our monitor also. But here I am watching on the main monitor supplied by the company. So you can see you can study the entire pelvic LIC system again. As I said, you can go into each and every calyx, examine that if there is any stone which was not located. This is a large stone. Can you see that?
Yes, we can.
Okay, and here I go into
how many number of hours does this scope run for? Is there any restriction?
Yeah, this run only for 4.5 hours. According to my information.
Okay,
so you can use it maybe if you really want to reuse it. Then in that case, maybe this is slubbed up papilla, you can see here.
Yeah, it's very clear.
So this is the vision with the Boston. I can continue with this Boston also, and because I wanted to show the vision with the Indovesi also, we will switch on to Indovesi monitor. Of course, it can be connected to our monitor also, and that is what we have done. So I will replace the scope if it is okay for you. Nanjappa?
Yeah, it is okay for us. Yes, it is okay for us.
Okay, so fine. So now just again see the anatomy. This is the ureter, and you can, as you can see, that my access sheet is not in the UPJ. Okay.
Right.
This is the access sheet. Okay, so I just take out my scope and we'll replace the scope with the invasive scope. Can you please give me the invasive scope?
While we change the scope, do you have any criteria? Do you have any upper limit where you would do where you would not do RIRS?
Preferentially, I would like to do RIRS for a stone up to 2 centimeter in size. Up to 2 centimeter. If the anatomy is friendly for the lower calyx, also I will do RIRS. But if the stone is more than 2 centimeter in size, I must explain to the patient that I think probably PCNL or mini PCNL would be a better choice at this moment. Maybe with further modification or the advancements in the energy, maybe we can extend the indication of RIRS. Extend the indication of RIRS for stone more than 2 centimeter in size. But sometimes when in case of a solitary kidney, anomalous kidney, or very choosy patients, sometimes I go beyond 2 centimeter, but I must explain to the patient that I might require to do surgery in 2 stage. That is what is very important.
While at this scope, Kandar, can I ask you that how do you reprocess this scope, this endoscope?
In my hospital, you can see all the instruments, even the cameras and everything. They are not covered with any cover because we have a sterile sterilizer in my hospital. So we do a sterile sterilization for all the scopes. for every single scope, all the accessories, whatever I am going to reuse, we will do it with sterile sterilization. So that Indovasive also you can do a sterile sterilization. Indovasive or Boston Scientific, whatever you want to use, reuse it. Can I have the vision?
So there is a
Do you
comment.
recommend high level disinfection for accessories and for the scopes?
Sorry?
Hello?
Just
Yeah,
hold
do
on.
you
This,
level-
hello. I want, excuse me. I want this scope vision here. So we have connected the scope. Yes, sorry, but yes, please tell me.
No problem, no problem. I just wanted to know whether you recommend high level disinfection for, you know, for the
So
scopes.
when I actually
using
using Parasafe for Sidex, that's what you meant to say?
yes, yes, yes.
Okay, so in my initial practice, we used to sterilize all the instruments with the Sidex or a Parasafe, but I think we stopped doing since last 5 years. When I started using steroid, and our infection rate has really gone down. I must tell you that, of course, the infection does not only depend on the sterilization. Your technique also is very important. Intrarenal pressure is also very important. Accessories also play a significant role. But I think one of the.
But I think we should not give the message that without a steroid, you should not start the program.
Of course not.
I think there can be high level, proper high level disinfection can also be done.
Of course not. Many people are doing a Parasafe and complete nice cleaning of the instrument, drying of the instrument, and proper care of the instrument. I think probably you can, you even if you don't have the steroid, it's okay. You can use even ETO also. I think it is cheaper to buy ETO. So I think now we have the vision with the Indovasive. I think the vision will clear in a minute. Just the moment we flush some fluid inside.
There is a comment from one of the audience that
Yeah, please.
Boston scope, you need to go very close to the stone to see it because of the light issue. Or do you also feel so?
Which scope?
With the Boston scope, he is written that unless close to the stone, you are not able to see the stone clearly.
No. I think Boston Scientific's scope is very good. The depth perception is very good. So I don't think that's my experience at least. You can see now you can appreciate the difference between the vision of this both the scopes. Can you see the stone now?
Yes.
This is Indovasive scope I am using.
We can.
Okay, so this is the
excellent vision which we are getting with the Indovasive Indian scope.
Yeah.
Is this the Indovasive sleek or is this the Indovasive normal scope? I think now Indovasive has stopped manufacturing.
Yeah, this is
their BioRed has stopped manufacturing.
This is Indovasive Slick 7.5 French.
Sleek. Yeah.
Okay, so now let me insert the laser fiber so that we can now speed up the procedure. But I think vision appears to be very good with this scope, and because the scope lasts for a very long time, I think probably in India, I think many people will start using this scope because ultimately it becomes cost effective, and even if you break the scope by any chance, you don't lose a lot of money. They tell it as a disposable scope, so we should also promote as on an academic forum. We must tell that this is a disposable scope, but most of the people in India, they are using it multiple times, so that I call it as a limited use ureteroscope. Okay, so now
very soon I think India will be teaching others how to reuse your scopes. With a lot of applications coming in, I think we should not keep it in that way, because a lot of data coming into how to reuse properly your scope, not just do it in a way which we consider is right. So
okay, so I start the case now. This is
what I'm noticing here, Kandar, is that the working channel is coming from a very odd position. Is it of going to be any significance to you, or is it okay?
Right now doesn't affect me at this moment. I don't think it is hampering my any vision or my movement. Okay, so we are starting with the no 0.2 rakho, 0.2 rakho, 0.2 joule and 50 hertz. So the total energy is 10 watt. Okay. The
Here,
frequency
can
is
the pulse
more.
width be set? Can the pulse
The
width be
pulse
set
width
here
is
on this machine?
yes, pulse width is medium. Because it has been observed that with a very short pulse width, the thulium fiber energy does not work very well. So it's a medium pulse width, not a long and a short. And let me see now. We'll start.
So does this machine have any presets compared to
You can fix your presets. I have fixed my presets. So now one thing you must have noticed that when you touch, you have to be very close to the stone, first of all. And when you sometimes dig into the stone, there is a sparking effect. So if you are very close to the mucosa, you have to be very careful. But you can see the kind of dust I'm producing. This is a painting technique I'm demonstrating. You can see that by moving my hand from one place to another, keeping your laser fiber constantly moving over the stone. You can even write your name with the laser fiber if you wish. And but the kind of dust you can appreciate, that is very fine dust which is produced. Can you see that?
Yes, sir. Yes, sir.
Yeah, because very beautifully demonstrated. Even the movement of the stone is less, no retropulsion. So it
Yeah, there is no retropulsion and a very fine fragmentation, and it acts like it is very quick. So I will try to initially, normally what is my philosophy is to reduce a large stone into a small size by producing a fine dusting. Once I just wanted to demonstrate this sparking effect. You can see the sparks?
Yeah, we can see the spark.
So that is the worst part of this machine. So that's why I'm keeping it slightly away from the stone, but then the effect of delivery is less. So
do you feel that has anything to do with the pulse width?
I think this is an inherent property of this thulium fiber laser, and with the hard stone you appreciate this. But when the stone is very hard, I have experienced that you are in a position to produce a very fine dust, which we call it a golden dust. The first case was a very soft stone. So the moment you apply laser energy, it will break. Even if you try to produce a dust, sometimes it is not possible to produce a very fine dust. Like in this case, what I am producing. So this is a painting technique. Another technique is a chipping technique. If I can chip the stone at the periphery. This is applied when the stone is not stuck to the mucosa. Thulium fiber laser is a good dusting laser. It is not a good fragmentation device. Okay. So some people are hesitant using for the PCNL. I don't have much experience on this, but because it produces a dust, and in PCNL you are trying to bring out all the small fragments. So because it is producing dust, they are not very happy. And we'll see that within how much time this hard stone, the HU is very high, 1400, but you can see that it is working very well. So this is the energy setting of 200 0.2 joule and 50 hertz. Now we'll increase the energy level to 0.2 joule and 100 frequency. So the total watt will be
20 watts.
Okay. So now you can see the difference. Because we have increased the frequency, the procedure will be much faster. Only thing is that when you increase your frequency too much, sometimes fiber wobbles. But with 200 you are okay. Never exceed your power be above 30 watt. Okay, always remember that with the thulium fiber laser, because it's a 60 watt, you don't try to increase the energy up to 40 watt or 50 watt. That you need only for maybe for the prostate. I don't have much experience about the thulium fiber enucleation of the prostate.
And here you are in the kidney, so you know that the frequency can be increased right up to 100 or whatever. But in the ureter, do you recommend these settings, or do you don't recommend these settings? If you
then in ureter, okay, in ureter I keep my frequency to 50. I do not exceed more, or you can even still further reduce. Huh?
Yeah, you can. I mean, we can go from a still lower frequency if it is okay.
Every case is a different case, and I think you have to start with the minimum energy and then exceed your energy level. Do not try to yeah, please tell me.
Burn back of the fiber, burn back of your fiber. Do you feel that holmium fibers burn back more and thulium burn back less? Is there any experience on that?
That is because in holmium laser you need to use a higher energy, so higher joule. Here your joule is only 0.2, right? And so fiber burn back is comparatively less with the thulium fiber laser as compared to holmium laser.
Kandab, you have allow me to ask a question. Thank you for inviting me.
Please go
Yeah,
ahead.
yes, Said. Thank you. Thank you. Nice to talk to you.
I have two questions. What about the thorium on the cysteine? We have seen some Russian group. The cysteine is very charming and black, and the efficiency is not that that expected. And the second question, with these advances, do you think the mini perk, if you have a patient with 1.6 centimeter and you optioned him would be between mini perk and use some mini perk use a thorium laser, or you have it flexible with a thorium laser, but the flexible, the advantage you having the ureter on the axis. The thing here that where we are going to kill the mini perk with this technology, or will those people will stick to their minds? You know, I remember when Alkin introduced the PCNL in 77, they were fighting him a lot with the open surgery. So I don't know where we are going. Give me your thoughts.
So to answer your second question first, I believe that you should do what you are good at. Actually, there are so many people who are not very good at PCNL. I think RIRS is a very, very good option, especially for the stone up to 2 centimeter in size. Or if you believe that this dusting is okay and patient gets good result, and if you perform a good job, I think I incline towards doing RIRS. I don't say that it is going to kill mini PCNL, but if you remember, I have my debate with in World Endocrinology Conference in Abu Dhabi, and I prepared one flyer actually for the presentation PowerPoint slide, and where I said that rest in peace mini PCNL. But I think that was a debate. That's why I did it. But I think both the procedures are complementary to each other, so I have no business telling at this moment that it is going to replace mini PCNL. But I think most of the people, I think they will, once they know the procedure well, I think they will do RIRS. Why to take chance, you know, of a bleeding or kind of a some complication. Most of the patients with the RIRS, they go home very next day and they are back to the work immediately, no pain. So I am very much inclined towards RIRS because it's my first love. So I don't know what is the thinking of the audience. And second question, the answer to the second question, I think you said about the cysteine stone, if I heard it correctly.
Yes, sir.
Correct.
So I don't have much experience about cysteine stone, because cysteine stone we don't find in our regular practice in India. I think at least in this part of the country, I have operated 1 or 2 cases in Turkey where I performed a robotic flexuretroscopy, and that was my first experience doing actually the cysteine stone. So I think maybe you can probably answer it or share your experience with the cysteine stone.
Do you want to comment on that, Dr. Said? Your experience with cysteine stones and PFL, I believe, is what you asked.
I don't know, I have a doubt that the thorium is giving charring. It's very nice for dusting, but I'm always having problem with the backburn of the fiber and the black color over the stone. So that's the main problem, and a lot of air, and the smell is
the bubbles that you
see. We are fortunate that this one is like very rare disease, so it's not like
so with the laser fiber sorry, with the laser fiber, I have replaced the stone into a comfortable position without using a basket. Okay, so
excellent.
Yeah, so
you can see the basket.
Today,
you need the baskets.
Dr. Said, today we are not seeing much of carbonization in this particular case. Not many bubbles either. So I think Kandar sir is using some trick to.
I don't know. maybe
So
your
3 out
blessings
of
are
5
working.
questions in the audience are also about the carbonization and the temperature and all that. What is the exact distance, safe distance of the fiber from the stone with TFL that you are taking?
Okay, question is for me or side?
It is for you, sir.
Okay, so normally it is said that you have to be very close to the stone, but like I do in a holmium laser, I'm just keeping a slight distance between the stone and the, or maybe I'm just touching the stone. That's why there are less sparkling. The moment I dig in inside, you can see that there will be sparkling like this. But if and there will be carbonization. But if I'm not digging inside the stone, maybe you can see here there are no sparks, no carbonization. Can you appreciate that?
Yes, sir.
Yes.
Yeah, I'm moving my laser fiber very gently over the surface of the stone now, not digging the stone. So maybe that is the reason why I'm not getting a carbonization in this patient. Look at this. And
Very nice.
the moment you go in the stone or dig the stone, I think you will get the sparks. So are you happy with this frequency, or you want me to cut down the energy and increase the frequency? Just for the demo.
I think this is
How comfortable you are, you can do that, Kandar.
Yeah, I'm perfectly all right. No problem.
Sparkling, I think we even see with holmium laser. We do see it with holmium laser, but the frequency I think is not too high, which we are using. So we don't experience it as much as what you are doing it now with thulium. Your experiences on that?
Correct. I don't get much sparkling effect on with the holmium laser. Very rarely I get. Maybe the frequency is less. I don't know. And you are not touching the stone. More important thing is that you are keeping the laser fiber slightly away in case of a holmium laser, because you have allowed that water bubble to act also. Here the water bubble is very small. So for the water bubble to be effective, your fiber has to be very close to the stone. Otherwise, supposing if I fire laser here like this, the energy won't reach. The energy won't reach to the stone. Can you see that? So you have to be close to the stone, so that the bubble will destroy the surface of the stone. You know.
Do you use a cold do you use a cold irrigation or normal temperature irrigation? Because one of the stated article by Olivier, he said in the high power laser machine you need the water less than 25 degree. In the 30 watt or intermediate you use a normal temperature saline. What about the thulium with your practice?
Okay, so I am using a regular saline. It's not a cold saline. But what another trick to avoid this thermal injury is to wait in between. So that what will happen, that the fluid will be drained and the excess heat is in. So the temperature rise won't be too much. So instead of using a cold saline, you can use cold saline, but what I do is that I fire the energy intermittently. Some people keep on firing energy continuously. So then that time it might raise the temperature within the system. Second important thing is that you do not exceed your power above 30. Because I have seen some people, even I, in the initial practice, I tried once using a maximum power of the machine and I burnt my fingers. So, burnt my fingers mean when I reassess the pelvic alysis system of the patient, maybe after I think 12 days, that time we could find lot of the mucosa was not very friendly. You know, I was really scared looking at the mucosa. So I thought that it's not a good idea to exceed your power above 30. I would like to restrict it to 20 actually. You can see that stone is very high. Now in this patient, some people may try to fragment the stone. Then you will leave multiple fragments and then the entire fun of the RIRS is gone. Because then it is like intrarenal lithotripsy, like what we do a shockwave lithotripsy. We do intrarenal lithotripsy. So I believe that spare 10-15 minutes more in overall it is not going to make a difference of more than 10-15 minutes, and the patient will be happy with the result. Of course, it is quite boring to watch this sometimes because you constantly somebody is hitting the stone and producing fine dust, and but that's the way it goes. No problem.
Very nice.
It's never boring to watch you, Kandar. Don't worry.
No, I know. I'm trying to, move my laser fiber from one position to another and trying to reduce a large stone into a small stone till I reach to the center of the stone. Sometimes, and the idea is, the trick is to go from the periphery to the center like this.
Do you always like to break the stone inside the pelvis, or do you like to take it to the calyx and make it there?
Uh, I'm not very, it's theoretically it is good that you take the stone into the pelvis so that you, calyx, so that you break the stone into 2-3 pieces and the fragments will stay there. Now in this patient also right now, because I'm producing little more deflection, what I'm doing is I'm advancing my laser fiber a little bit and deflecting up so that I can comfortably place the stone in a desired look. Could you see that?
Yes, sir.
Yeah.
Without using a basket, sometimes I have demonstrated sometimes in conferences that I try to drill the stone when I'm using a Holmian laser energy, and with the laser fiber only I shift the stone from lower calyx to the upper calyx. So you can avoid using a basket if the pelvic elevation system is friendly, and if the infundibulum is wide, you can do that.
Do you have any experience of that jacket on the laser fiber? Because we are not stripping it. Does it have any, does it fall into the pelvis, or does it get burnt out and pieces are there in the pelvis? Any study or any experience on that?
Yeah, I have seen the jacket falling off in the kidney sometimes, yes. So Dr. Strexer said that, you try to clip the fiber every 15 minutes. So 1 centimeter of the fiber is clipped so that there is an efficient delivery of the energy. Okay, one more interesting thing I would like to share with you. With this thulium fiber laser machine from Quanta, I'm not very sure whether it applies to IPG also or not. The same laser fiber can be used both for Holmium and the Quanta Holmium machine and thulium fiber laser. I don't know, IPG has some separate laser fiber for the thulium fiber laser machine. Any idea? Anybody? Said, you have any idea?
Syed is not online. I think IPG doesn't have IPG has a Holmium machine.
No, they don't have.
I don't think so.
But
yeah, so I think that would be basically because of the connector which is there, the SMA connector which is made. So I think the connector, if it's the same, then you can use it for any of the machines.
Yes, sir.
Okay.
Yeah.
Because
Do
I was
you have
surprised
any tips? Yeah, Kandar.
I was surprised when because I got both the machines. So when once they say that you can use the same laser fiber in both the machines, initially I was a bit surprised. But you are seeing it that this is the same laser fiber I used for the first case. The second, which we use the Holmium laser energy, and now we are using the thulium.
But in the Holmium, we cannot go below, I think, below 200 micron. We should not go below 200, because in these machines, I think we can even use a 150 micron fiber in the thulium fiber. But the same 150 micron cannot be used in a Holmium.
Correct.
Because the size of the fiber, you cannot go below. Yeah.
Correct.
Because that beam profile is different compared to the thulium beam profile. So that difference we should have. Kandar, about the way you're now, I was just going back to that question of, from where your working channel comes out. Has it any role to play in which kidney you can use that scope? If you have a 3 o'clock or a 9 o'clock working channel, any difference it makes in using your scope in the right kidney or the left kidney? Here with your, your fiber coming out at here, it's 11 o'clock.
Of course. So different fibers, the scopes can help you in a different situations. But as my professor, Dr. Oliver Drexler, said that for the left side, I think you are better off using a 3 o'clock channel, and for the right side, you use a 9 o'clock channel. Frankly speaking, I decide on the one particular case only. I do not stick rigidly to that idea, because I feel that you should be comfortable using whatever machine you have, whatever scope you have. But at the same time, there are some situations where if the fiber is coming from the 3 o'clock positions, you will be in a position to focus the laser fiber properly over the stone, because sometimes there is half moon effect you get when you enter into some of the calyx. So depending on the case, you decide, rather than being rigid about the right side or the left side. That's my thinking. Of course, I may be wrong, but that's my thinking.
So we could appreciate that there was a small fragment created there, but while you are breaking it, it's not really moving away from the stone like it would happen with holmium, sir. So you
Yes.
could make smaller fragments of that then and there itself. What irrigation are you using for this case, sir? Same syringe irrigation?
Same irrigation. You can use a gravity irrigation also. Sometimes we do that also. But if your assistant knows how much pressure to apply while irrigating the system, you are fine. And so constantly we are keeping a watch on the output from the water output from the ureter access sheet. You know, it's very important that, and I'm extremely careful about it. Otherwise, it will raise a lot of intra-renal pressure. It may damage the kidney, and you don't realize.
Do you feel the temperature of your outflow sometimes increases with thulium fiber?
Yes, yes. If you increase the energy, yes, if you increase the energy too much, it can happen. So you must have appreciated that in between I'm stopping. You know, in between I'm stopping, so that there is no the fluid is drained and the fresh fluid goes inside, so it does not increase the intra-renal pressure too much. Some people keep on firing the laser for at least 5, 7, 10 minutes continuously. That you can do, but I just wait like this, so that gives me rest also a little bit. And okay, so then I'm not very much worried about the damage. Now you can see that there were 1 or 2 small fragments, but I think later on we'll tackle with them, or maybe if necessary we can take out those fragments also. Some people have a habit to produce a popcorn, so they ship the stone into a calyx which is not a very wide mouth calyx and very large calyx, so moderate size calyx, and you can start performing a popcorning. You can do that. I'm not a big fan of popcorning. The reason is that you have to continuously fire the energy, so that is a possibility that it is likely to cause very high temperature. Secondly, when you do popcorning, you have to flush the fluid with little more pressure. So in that case, intra-renal pressure rises significantly high. So that I want to avoid. So I normally do not intend to do a popcorning technique to begin with. If at all I am forced to do it, I will do it. Otherwise, not. Otherwise, in this patient also, we could have pushed this stone into one calyx and start firing haphazardly, constantly, and then maybe you can finish the case early. But they're leaving a lot of small fragments, which I want to avoid.
We are seeing some bubbles on your screen.
It would be more of pop dusting, I think.
If you are seeing the bubble, just do like this, you know. Now,
is it only with TFL that these bubbles are there, or the holmium also?
There are no much bubbles. I mean, I'm not very sure how much you are appreciating, but here the things appear okay. Of course, when you say it so, that time there were 1 or 2 bubbles, so they were distracting my vision. You can, at the bottom of the screen, I think at the 5 o'clock position, maybe you are seeing some kind of a distraction, but that is not hampering my vision, so I am fine with that.
In spite of such beautiful dusting, Kandar, we are seeing that the vision is so good. Any trick how you are managing it?
Maybe
assistant only there.
Of course. But secondly, if you increase your frequency, supposing if you increase your frequency beyond 300 in this patient, you will get a snowstorm effect. So that also I want to avoid. So I'm not increasing my frequency. I could have used more frequency in this patient, but I'm comfortable. I think, what do you think? Should I increase? I am fine otherwise. What do you think?
No, you're fine. You're doing a very good job. Everything. I think, do you feel in the future the thulium fiber laser would come with softwares where they will limit the frequency of the machine? Because they have given you a machine with lot of abilities, but it is maybe sometimes dangerous to use that power and the frequency. So do you think in the future we will have machines where things will be limited rather than giving you the complete potential of the machine to be used and cause damage? Do you think that there will be software just to limit that frequency and everything?
I think to answer this, I can say that it's like having a knife in your hand, and you can either perform a nice surgery with that knife, or you can kill somebody. So it's all up to you how you use it. But you are very correct. And I think there is some company which has come out with a hybrid model, some kind of a laser machine, which is, I think probably Lisa has come out with that, where they have restricted the frequency to 300 only. This is a recent thulium fiber laser introduced by Lisa, if I'm not wrong, and where they have.
You're talking of the thulium YAG laser, which has been introduced by Dornier, called the thulium. Are you talking about that machine?
I have no idea. I just heard about it. So where they have restricted the frequency to 300. But thulium fiber laser and thulium laser both are completely different thing we are talking. So one has to be very careful that when you say thulium fiber laser, it is different thing, and a thulium laser, which is again a different thing. Okay.
So even
I think Dornier is launching a machine with the thulium YAG with a diode, which is going to fire the laser rather than the flash lamps. So I think that's just been introduced in the market. So where the frequency would be really high.
Yeah, it is the same
it's a pulse laser rather than the.
Yeah,
it's the same thing with laser. Okay.
And there are some out of it.
Oh, sorry, carry on.
Sure, carry on, Tanush. Carry on. Yeah.
Hybrid laser. Even we thought it is a mix of thulium and holmium or something, but it's actually a thulium YAG laser in which they have introduced pulse modes and adjustment of pulse width and all that. So it's a hybrid laser, which Lisa has come out and Dornier also has come out. And there are some more companies working on it, sir.
Okay. Now what we can do is that I just want to demonstrate one more thing, the chipping technique. Here you can chip the stone, the size of the chip will be less than 1 mm. You can chip the stone like this. Go to the periphery and start chipping the stone. Rather than making a dust, you can chip. Could you see that chip?
Yes, sir.
Yeah, so you can chip the stone. Sometimes you can do it.
You have not changed any settings for that?
Huh? No, nothing. It's the same setting.
Only you're sort of drilling into the stone.
Yeah, so I'm just touching the stone at the periphery. It's like chiseling. A very, very fine work we are doing like this. And then follow the periphery like this. Just be careful that you don't hit the mucosa, okay? And sometimes because of the respiratory movement, there is a possibility. Now this last fragment, this also you can appreciate that it won't move much. And I will fragment, make it a dust, or maybe I can take out with the basket later on. Let us leave it at.
We have Dr. Mahesh Desai here. Sir is there online. So I would like to, he has a tremendous experience on using the thulium fiber, and I think they have the new generation of, I think the software, second generation of IPG. So sir, can we have your experience on the thulium fiber? Sir, your...
Yeah, I've been... Can you hear me?
Yeah, we can hear you now, sir.
Yeah. So I've been using thulium and holmium both, and trying to find out which is the best settings and things like that. What Kandar is doing is beautiful. I know he is making very, very small dust and or a small fragments, and the trick which he has showed, that you go to the periphery where you break the stone into a small particle rather than in the center where you make all the dust. So he's doing evenly to get the stone into a passable. If you break the stone, which then you have to pick up with a basket, that will be a little larger stone. And with thulium, you will have the stone which are less than 3 millimeter or 4 millimeter, which will pass it off or suck it out. So that is but he's doing very nicely. He has been breaking the stone and disintegrating.
Sir, you have a large experience of Moses technology also. Could you please share your experience with the Moses technology, which is also used for producing a very nice dust, as well as to avoid the retropulsion?
See, what I do in Moses is when the stone is solid, you can use a contact mode with depending upon the Hounsfield unit. I adjust the power and the frequency. Usually frequency is not much more, either 30, 40, 50 or 60 or 70, you can play with that. But energy can be more depending upon the density. In thulium, is other way. You keep the energy very minimum, but the thulium and the frequency, you can go up and up. Now, what I do in Moses is in the middle, I do the contact mode. But when at the periphery, I do a non-contact, which is little 1 or 2 millimeter away. So it doesn't break in the big fragment, but it makes chips. Because if you see in the center, the stone is very solid, while in the periphery, the stone is can get into a little bigger chipper and which can fly off, which can give a little trouble, or you may have to pick up with the basket. But in Moses, what I do is at the periphery, I do a non-contact, so it still gives a small fragment or a dust. Now you see that chips now, which has come out. He has to make it a little smaller, otherwise it will give a problem. So he will probably go back again. Now he's going back again, and you can see the stone is getting smaller and smaller.
Okay, so now you could see that
over the period you will get the experience, and now see the stone is turned and it's the solid part. But what I find that at the periphery, the density is not that much, so you can get into a chips mode. You can see the chips lying around, and that while in the center, when you are doing, you can see the dust flying off. So, and this you have to use it very, very, very.
So, what is your experience on the rise in temperature?
Well,
over the last
actually,
thulium fiber.
There is a definitely rise in temperature. So, but if you have an irrigation and if you use the low pressure, like for example, here in the flexible urotoscopy, definitely the temperature will little go up. But what I do is I use a sheath with suction. So, and the water is sucked out and then new water will come in. And this same thing I use in PCNL, where I use a suction mode. I think suction mode will come. This will have a two advantage. One is it will not allow the temperature to go up because it will be constant flowing. And the second thing is it will keep the intra. So it does not intravasate into the tubule. So the post-operative pain and the discomfort will be less. So here you can see the lots of dust flying off. You see that?
Yes, sir.
And that dust will pass off very, very easily.
Okay, so now what I'm trying to.
Suction now. So are you using a suction with an access sheet? That's what you all have been using now?
Yeah, I've been using sheet with I've not been able to measure the temperature, which is try to do it. We have been able to get one equipment where we are trying to measure the temperature. But in PCNL, I use quite a bit this technology with mini perk and the suction and the laser. But where there is a continuous suction is on, so the temperature doesn't rise. That we have checked it up. But here, temperature can go up. So either what I do is in a very large stone, I may, like this stone, I may go for a mini perk. And if there is a small stone in somewhere other calyx, I can use a flexible scope and then do. In that case, the pressure would not go up because from the PCNL's sheet, it will suck out. The pressure.
Professor Texture has joined.
Sorry?
Yeah, he is joined. He is there online, but Dr. Traxer, video is not on. Yeah, he's on. He's there.
So you can maybe
Good
you
morning,
can.
sir.
Hi,
Hello.
Oliver.
Hello, hello.
Yeah,
Hello,
Dr. Traxer.
We can't see.
Good morning, sir. Sir, what is your take on thulium fibers? A lot of things going on discussion. So we wanted to know whether there's going to be a cap on frequency of the fiber in the near future. So
you would like to know what is my experience in general with the thulium fiber?
first, yes, and whether there's going to be a cap on the frequency of the machine, whether you are having an overkill, you are having something much more than required given to you, and you don't know, so whether you have something like that going to happen.
Okay. First, you know, I would like just to talk in general when we are talking about lasers. I think all of us, we did some mistakes since 20 years when we were talking about the settings. I think that many people were focusing on the level of frequency. And you see, when you are asking me, when I'm thinking about fiber, you are asking me regarding this frequency. And I think that it's a mistake. You probably know that Olympus recently, they did some recall regarding the Soltive thulium fiber, because the presetting that they put in the system, and I would really not recommend, I'm sorry to say that, but I would really not recommend to follow the setting that they put in the system, because they were focusing a lot regarding this high frequency, thinking that this is the main point, the frequency. In fact, if you talk to engineers making lasers, they never talk about frequency in terms of low or high frequency. They are talking about total power, watts, like 10 watts, 20 watts, 30 watts, and they are talking about the energy per pulse. So if you remember the formula, energy by frequency, and then you obtain the power. If you fix the power, if you fix the energy per pulse, of course, you will get some frequency. So my message is very simple. My message is, when you set a laser today, and especially when you do it with the thulium fiber, because it's a very powerful system, don't consider the frequency as the main parameter. You have to consider the energy per pulse you are using, because at the end, the energy will produce the effect. And you have to fix a limit in terms of total power. Because if you consider just the energy and frequency, and you push the frequency very high, thinking that's the good setting, then you will have a total power really too high when you do endoscopy, especially into the kidney. My recommendation today, when you in terms of total power, is no more than 20-25 watts into the kidney. So if you need some energy, I don't know what KP is using just right now in terms of energy per pulse, but for example, if he's using 0.5, I will not use my frequency more than 50, because my total power would be 25 watts. If he is using 0.2, since I'm able to go up to, let's say, 24 watts, then I will be okay to use 120 hertz. And I think that if you respect that, and it's even less into the ureter. Into the ureter, I would recommend not to go more than 15 watts. So I think saying that, my message today, I don't know exactly the good settings regarding thulium fiber. I have no idea about what we should really recommend to the people. What I can just recommend to you actually is be careful with the total power you are using. In terms of temperature into the kidney, in terms of risk to damage the mucosa, this could be dangerous. So be careful of that.
Okay, so good morning, Dr. Trexler. This is KP here, and I'm really happy that you could join us. And right now we are using 0.2 joule, and 100 is the hertz. So the total energy of 20. I do not exceed, as you said, more than 20. And before you joined us, I discussed with the audience that I would like to restrict my total power to 20 in my thulium fiber laser.
Perfect. Excellent. I think that's excellent. I see that you are using the fiber dust. It's a very
I'm using fiber dust, yeah.
Yeah, the fiber dust from Quanta system. It's an
Quanta
excellent
system.
I have also this system. It's very comparable to the Soltive, the Olympus one, or the IPG, the Eurolays. All of them, they are 60 watts. So it's more than enough for flexible ureteroscopy. Of course, I'm not talking about PCNL, I'm talking about flexible ureteroscopy. But if you look at the Quanta system, Quanta, they didn't put any pre-setting into the system, into the machine. And same for the Eurolays for IPG. And the reason is very simple. That nobody knows the exact setting we can recommend. So it's impossible to give some range for the presetting.
Sir, is there any advantage of the 2 pedals that come with this particular machine? Kandar, sir?
Sorry?
Is there any advantage? There are 2 pedals with this particular machine.
Yeah.
Do you find advantage in lithotripsy with that?
No, there is one is a continuous wave. This machine has got both the pulse wave and the continuous wave. So I think you can use that much if you want to use continuous wave, mainly for the laser, mainly for the soft tissue application. You have to use a continuous wave.
In stone lithotripsy, you don't find any advantage of the 2?
No. See, this is a little bit. I thought that I will be in a position to take out this stone, but I think at the level of the UPJ, it is blocking. So I will not try much, and I will fragment it further. So the large stone is reduced to this size. There was one more stone in the lower calyx, which is about 1 centimeter again. So I tried to, while you were talking to Professor Trexler, Panjalu, please. I tried to, deal with that also. So you can see all the small fragments. This part I will have to deal with still, because this is a lower calyxial stone, and this is the one which we are tracing up till now. So this is that large stone, 2 centimeter size stone, is now reduced to this size. You can appreciate that I can apply little more dust energy, laser energy, and we can deal with it.
I have a small question for Dr. Traxler. Sir, what is your take on suction now? There's a lot of discussion going on since morning about whether suction is going to be the thing, and suction with lithotripsy in flexible ureteroscopy.
So you would like to know what is my experience, you mean?
Do you yeah, your experience? Do you use suction with RIRS? Do you use what's going to be the future? And
no, still not. We still don't use any system actually to aspirate, like the Clear Petra, for example. I was a bit disappointed for flexible ureteroscopy with the Clear Petra sheath. So I don't use it regularly. I have no good systems actually to aspirate. I can just tell you that we are working a lot on the lab regarding a new concept to aspirate during laser lithotripsy. I must say that we have excellent results. I'm very confident that it will come very soon. good systems, very efficient to laser and at the same time to aspirate. I'm very confident that it will come in maybe, I don't know, maybe 2 years, 3 years, but companies are doing actually a fantastic job. And this is the only way, actually. This is the only way if we would like to improve what we do in terms of stone treatment, fragmentation or micro fragmentation, as you can see now with KP, is doing fantastic job. That's great. Even it's a big stone, he's able to do it relatively fast, actually. But we are still concerned about these residual fragments. So we need something to aspirate. No discussion.
So what's your opinion?
Please go ahead.
Can I take a question, this thing? Yeah. So what is your opinion on whether access sheath is going to be obsolete in the future? With the new generation prototype of scopes coming by, Wolf is already in the thing of launching a scope, which is a semi-rigid with a flexible into it. So do you think that access sheath in the future, like for semi-rigid ureteroscopy, is already being obsolete? Now for flexible also would be obsolete?
I think so. You know, we can imagine that if we are able actually to develop a system able to irrigate and at the same time to aspirate when we laser, it means that we will be able to control the inflow outflow for the pressure. It means also that we can control the high temperature level because the flow would be better. So if we can fix these two problems in terms of temperature and in terms of pressure, because we have a good system to aspirate, for me, yes, ureteral access sheath will become obsolete.
Manjapa sir, it's time for the...
So I think, Tanuj, we are almost finishing with this part of the stone. And because Professor Pekshar is here, I think rest of the job, I think, can be done in few minutes. So before that, if you wish, you can connect to Dr. Professor Pekshar for his talk, so that the moment he finishes his talk, I can give you a final look at the... is that okay?
Yeah,
Gandharv, can I ask you a question?
I think, Doctor.
Yeah. Yeah, please.
How do you compare the dusting of this machine?
Dusting of?
Oh, we can't hear. Who was?
Hello. Basket.
We can't hear the question. I think the question was, how do you compare the dusting fiber to the holmium? That is what I think the question is.
Dusting of the dusting of the thulium is much better than this the holmium, but in this patient you can't see that the kind of a dust which I normally produce, because it's a very large stone and very hard stone, and there are multiple stones. This is another stone which I am dealing now. The one which you show was is almost gone. There is a small fragment that I'm going to pick up. This is a lower chelation stone. So just to speed up the surgery, I am planning to give a kind of a popcorning here and finish the case. So
okay, Kandar, we'll give it on to Dr. Keshav Murthy for the further proceedings. Sir can take over.
Yeah.
But still wonderful demonstration, Kandar. Wonderful.
Yeah, thank you. And I will join you. I'll join you in about I will be right now. We will if you wish, we can switch off this the endovision, and maybe once Professor Pekshar finishes his talk, we will come back to you again and give you a final glimpse of the endoscopic vision. Is that correct?
No problem, Kandar. We can take a call, Dr. Keshav Murthy.
Dr. Anjappa, you can invite Dr. Oliver Traxler for his talk.
Yeah.
Endovision बंद कर दो.
Okay, Kandar. We will be keeping you on, but we will go on to the talk of Dr. Olivia Traxler.
Yeah. So, or else you can switch off this audio visual, endovision right now, and maybe you can focus directly on Dr. Traxler's talk, And then maybe after 15 minutes, once he finishes his talk, I can give you an endovision view.
Okay.
So, yeah, now I would request Dr. Traxler to give his talk. I mean, Dr. Traxler doesn't require any introduction. He's the world's best flexible ureteroscopy, who's all our guru, and we have been watching him since so many years. So requesting Dr. Traxler to put some new insights into the talk on upper tract urinary carcinoma and thulium fiber laser. Sir, it's all for you to take over.
Thank you. Thank you very much for the invitation again. I'm so sorry that we cannot meet live all together, but I'm sure that 2022 is supposed to be better. So I hope we will have the opportunity to be again all together very soon. So thank you for the invitation. I'm very happy to be with you today. And just to discuss a little bit about the conservative treatment of a urothelial tumor of the upper tract. We are not talking about stones, but since you know that most of you, since you are very comfortable treating stones into the upper tract, with the same equipment, you can also, because you are skilled, you can also treat urothelial tumor. And this is for me something very interesting, to see that we are not really a uro-oncologist, but finally, on this specific topic, I think we are much more efficient, technically speaking, than the colleagues, the uro-oncologists, because they have no good skills in terms of endoscopy. So I would say that it's interesting topic. So what I would like to do is just to give you some technical aspects, not only using the thulium fiber. I will mention the thulium fiber, of course, but I would like just to give you some general tips and tricks and technical aspects. Oops, sorry. Yeah, just to give you also my disclosure, I'm a consultant for these companies, and some of the companies are developing actually equipment that we are using for the conservative treatment of urothelial tumor. So what I said, my introduction, you know, if we consider endourology today, this is more or less what we do, 90% stone treatment, but in 10%, we also use the equipment for tissue applications. So I mean urothelial tumor, but also when we have to treat stenosis or sometimes benign disease. You know that urothelial tumor in the upper tract represent just few patients at the end, if we consider the urothelial carcinoma, because upper tract urothelial carcinoma, it's more or less 5–10% of the total urothelial carcinoma. There is no discussion that the total nephroureterectomy is still the gold standard. It's a radical treatment. But we also know that since sometimes we can select very special patients that we call the low-risk patient. And those patients, they are suitable for conservative treatment. What does it mean, this low-risk patient? It means a patient with a unifocal tumor, less than 2 centimeters. You probably know that since the guidelines from international guidelines, it moved recently from 1 centimeter to 2 centimeters. And low grade. And you need to have all of these criteria, unifocal plus less than 2 plus low grade. And if you have a patient like this, it means that this is the ideal candidate to perform a conservative treatment. You know that the grade is the main important parameter We can discuss about the unifocal or multifocal tumor. We can discuss about the total volume. Sometimes we can treat big tumor more than 2 centimeters because it's an easy one. Sometimes we cannot treat a small one because it's very difficult to access the tumor, and especially in the lower part. So the size, the multifocality is something we can debate. But I think for the grade, there is absolutely no discussion today that high-grade tumor, they are definitively not good candidates for the conservative treatment. Sometimes we have to do it because we cannot do differently, because it's bilateral tumor, or because the patient present very high comorbidities or renal insufficiency. So we still have to consider the conservative treatment. But we know that when we do the conservative treatment with high-grade tumor, most of the time there is a big risk to see a progress in the disease. So try to keep these indications exclusively for the low-grade tumor. Role of endoscopy is very clear today. We need to perform a diagnostic flexible ureteroscopy and biopsies if we are thinking that we will obtain more informations and that the informations will have an impact on the treatment decisions. So do diagnostic procedure very easily. For me, it's impossible actually to treat a urothelial tumor, even if we would like to go for a nephro-U, without performing an endoscopy with biopsy, just to confirm. It's so easy actually to do a diagnostic flexible ureteroscopy. Another concern regarding the follow-up, you know that it's a very demanding approach technique, and the patient should accept that the follow-up will be very strict, and he will have to accept many endoscopy, especially in the first 2 years, but also for a long time, just to be sure that he's completely treated. Just to give you some example in terms of endoscopy, diagnostic ureteroscopy, you see this one. If you see the radiographic picture on the left, you see that there's a big filling defect. It's not easy to make a conclusion on that. Look at the endoscopic view. It's very easy to recognize that it's a benign fibroepithelial polyp. It's very easy to remove. You just cut at the basis with the laser, and then you remove the complete polyp in one piece. But again, if you don't perform this diagnostic procedure, it will be probably difficult. Another picture on the left, you see this very small filling defect that you can see on all the pictures on this IVP. Again, if you go for endoscopy, you will see that it's in fact just a very small cyst in between two papilla, very easy to laser. This is not, of course, a tumor. Another example on this patient, it was a woman with a very tight ureter. So unfortunately, I was not able to place my digital endoscope. But even with the fiber optic endoscope, you can see that, again, it was a cyst on the mucosa, easy to laser, and there is no need for more treatment. This one is maybe more impressive. It looks like a urothelial tumor, very difficult to know exactly. We removed this one, and it was again a benign fibroepithelial polyp. I was a bit surprised by the final pathological results, but it was still benign. So remember that diagnostic procedure, you can use it largely. If you look at publications regarding diagnostic procedure, you probably know these excellent publications from Dr. Bagley, Dr. Grasser from the States. They were really the pioneer in this topic. They reported 13% of patients with no diagnostic at the end. But in fact, if you look at these publications that they did in the last one in 2012, you will see that they were still using fiber optical endoscope. They were not using the digital one. And this is, for me, the main reason why at the end they conclude with this 13% unexplained diagnostic procedures. Equipment, you need all the equipment. You need semi-rigid ureteroscope, and you need, of course, flexible one, fiber optic, and the digital one. Even today, we really promote the digital technology because the view is exceptional, as you know, and you will probably not miss urothelial tumor. But sometimes, unfortunately, you cannot use the digital one because the ureter is too small. And then you will be very happy to still use fiber optic. So be ready to use fiber optical ureteroscope in case of a difficult anatomy. But of course, the digital one are actually the one that we recommend. We have also different technology to improve the detection of urothelial carcinoma. We know this technology coming from bladder tumor. The first one was the PDD light with the XVIX. For some time, only one endoscope was available. It was an endoscope from Karl Storz. It was a Flexix 2 PDD light. It doesn't exist anymore, actually. So we cannot recommend today to use the PDD technology in the upper tract. Even some people did some experiment. I don't think it was an excellent tool. And today we have no more system with the PDD light, so we cannot recommend that. Of course, you know the NBI technology from Olympus is very well known, coming again from bladder tumor. I would say it's a nice technology. Personally, I was using this NBI largely with the original system from Olympus, the URF V, the video system. I must say that the second generation, the V2 or the V3, the technology is not so good compared to the original one. But when we use it in the past with the V1, we were able to detect up to 24% more urothelial tumor. It's also an interesting technology, the NBI, because you can also make some difference between the irritation of the mucosa and the real urothelial tumor. When you switch from the white light to the NBI light, you can see on the small papilla this black spot in the middle. In France, we call it the frog's eggs effect because it looks like a frog's eggs. And if you see this picture, this is a typical view of urothelial tumor. If you just have some irritation of the mucosa, inside you have no vessels, no small vessels. And this is the reason why you don't see this black spot in the middle. It's also a nice technology to detect a very small tumor. You see on this picture, even I'm using my digital technology, I was not able to see really the tumor. But when I switch on the NBI technology, then the tumor became visible. So it's a nice tool. It's not perfect. It's very easy to use because you just have to switch the button on off. So it's something that you obtain immediately. If it helps, I would say it's good for you. If it doesn't help, that's not a big problem because then you come back immediately with a white light and then you can proceed. So this is our initial experience with the NBI. We published in 2011, so it's more than 10 years now. I just realized. And again, we were able to detect up to additional 24% of tumor. From Karl Storz, you know, Karl Storz, they developed the 1S technology. Previously, we call this technology the SPICE technology. We have 6 different modes, from the white light to the spectra B. To be honest, I don't know exactly how to use this technology today when I'm doing my urothelial tumor. For me, the best mode we can use with the 1S technology is probably the spectra B. It's something a little bit equivalent to the NBI technology, even it's not exactly the same technology. I also like very much the Clara and Chroma mode. Then you have much more illumination, much more contrast, and it also gives you some a feeling of a 3D picture. As you can see on this slide, if you look at the third picture on the right and up, you see that it gives some feeling of a 3D. I like these ones also to do stones, but I cannot tell you that you will detect more urothelial tumor just because of this technology. And I don't think today that, again, we have good data to support the benefit of the 1S technology. We have also different technologies that you probably know, the cell video or the OCT. These 2 technologies are interesting in terms of research to detect for the cell video, this is to detect high grade and low grade. And for the CLE, it's a little bit more to see the deepness of the tumor into the ureteral mucosa. Interesting for the research. I don't think that we can recommend to use this kind of technology actually in the regular practice. So what are the alternatives for the endoscopic treatment? We have 2 alternatives. We can go percutaneously. Since a long time we do PERC to do conservative treatment. We know what we can do and what we cannot do, of course, with percutaneous access. And of course, more recently, we developed the retrograde access. We need to keep in mind that percutaneous access should be considered exclusively when the retrograde access is not feasible. And to be honest, I must tell you that I'm doing a lot of conservative treatment every week. I cannot remember one case we were forced to move for a percutaneous access. Today, if you have all the equipment available in terms of flexible scope, in terms of lasers, in terms of disposables, you can do more or less all the patients retrogradely. The situation where percutaneous access is very interesting. That's for patients with urinary diversion. If they are internal or external urinary diversion, then percutaneous access, of course, plays a major role for the conservative treatment. So regarding the URS technique, again, I would like to acknowledge these 2 pioneers, Dr. Bagley and Dr. Grasso. You know that they did a lot since a long time to describe this conservative treatment, and they design what we call today the no-touch technique. It means that when it's possible, you need to try to go into the collecting system with no trauma. So it means no guide wires, no safety wires, no ureteral dilatation, and no ureteral access sheath. So you just go into the bladder, and when you are into the bladder, you try to engage directly the ureter. And you need to have a virgin ureter to detect small lesions or some red spot supposed to be, for example, CIS. If you put a safety wire, you will damage the mucosa, you will create some small lesions, and then it will be difficult to know if it's due to the urothelial tumor or not. Respect very low pressure. Regarding ureteral access sheath, I would say, why not if you are sure there is no tumor into the Is it okay?
Sir, we are
Are you okay? Yeah.
Yeah, I think so.
Clean vision
Okay. I was listening to people.
Your audio has to go.
Kandar sir, we can hear you, but Dr. Traxler talk is going on. Yeah, it's muted now. Sir.
Okay,
please,
sorry.
Please go ahead. No, please go ahead, Professor Traxler.
Okay. So regarding these technical aspects, the first step for the technique is, of course, a regular cystoscopy. I think it's very important to have a good look of the bladder and be sure you have no bladder tumor associated. It's nice to have a look about the ureteral orifice, sorry, to see if the ureteral orifice is large enough, meaning that you will be able to do the no-touch technique, or if you will need a wire just to engage the distal ureter. So again, very important to do a good systematic cystoscopy. For the no-touch technique, so to engage the ureter using your flexible ureteroscope, it's not very difficult. And you can train yourself when you do stone treatment just to be skilled when you will need to do it for a conservative treatment. What does it mean, this no-touch technique? You need to realize this sequence in terms of manipulation. You need to rotate the endoscope. When you are into the bladder, you rotate the endoscope, and doing that, you will see the left and the right orifice. Then you have to deflect to place the orifice in the middle of the screen, your video screen. And when the ureteral orifice is just in the middle of the screen, you just push, you advance the scope to engage the scope, the endoscope into the ureter. So just to show you with this small video, you see first you rotate, you enter the bladder at the bladder neck, you rotate, you see the left ureter and the right, and you will see that the right is relatively large. Then you deflect. And when you deflect, you are moving the orifice from 12 to 6. You stop when it's into the middle of the screen, and then you push. You advance the scope, and you see that you will engage the ureter. Again, this is really not difficult to perform. And you can train yourself again when you do stones. And then you will see that after some times, you will be able to do it regularly. To be honest, that's what I do today for most of my cases, including the stone cases. I go directly with my digital flexible ureteroscope into the bladder. I just engage my ureter. I put a safety wire for stones because I still use regularly safety wire. If it's a diagnostic procedure, if it's a urothelial tumor, I don't put a safety wire on this case. In terms of biopsies, you can use the regular basket that we are using, the Nightingale 1.9 or less than 2 French. If it's an exophytic tumor like this one that you can see, you just trap the tumor and then you strip the tumor, and then you have a very nice piece for the pathologist. You can also use some graspers. Biopsy forceps. We have 2 different ones actually, the Piranha from Boston, the biopsy from Cook. For sure, the biopsy is much better because you obtain very big biopsy compared to the Piranha. It's at least 3 times superior in terms of volume. But as you know, it's a very big instrument, and you cannot go through the working channel. You have to backload the instrument into the endoscope outside the patient, and then you have to come back into the patient with these biopsy forceps backloaded. So it's not easy to use without a ureteral access sheath. But if you need it, I think it's a good instrument. Personally, in my practice, I'm using exclusively the Piranha basket from Boston Scientific. It works very well. I just repeat, I do 2, 3, 4 biopsies until I get enough tissue for my pathologist. 2 small tips and tricks. If you have a tumor into the renal pelvis, as we said before, you catch it first, and then you pull, going to the bladder, you can pull the tumor, and then again, you will obtain a very nice sample. If you are into the ureter, I do a little bit differently, not to have too much tension on my ureter. You know that the UPJ is really fragile. So if you catch a big tumor and you try to pull to the bladder, there's a big risk to put too much tension on the UPJ. So what we do the opposite. We catch it first, and then we push the basket to the kidney. And doing that, you will detach the tumor, and then you can pull the tumor outside. So this is just a very simple trick to preserve the UPJ and to have no problem in terms of stripping. In terms of laser technology, holmium-YAG is of course completely validated actually for the urothelial treatment. You know the holmium-YAG. What are the settings? What we recommend actually is to select first a long pulse duration. As always with holmium, when we do tissue applications, we much prefer the long pulse. For the energy, it depends of the technique you are using. But this is something between 0.6, 0.5, 0.6 to 1 joule. And the level of the energy depends about the distance that you respect regarding the tumor. If you like to be in contact with the tumor, use 0.5, 0.6. If you prefer to keep some distance, then use a little bit more. 1 joule is perfect. For the frequency, 10 to 15, most of the time it's largely enough to do the laser ablation. You know Marianne Bremer from Sweden. She's very well known for this conservative treatment. That's the recommendation of Marianne. Marianne is a very good friend. And you see that that's what she's using. She likes to use to coagulate long pulse 0.3, 30 hertz. So it's 9 watts. And for the ablation, she prefers to use, as I recommend also, long pulse 1 joule and 10 hertz. What I also recommend is to cut the tip of the fiber. There's no need to keep the transparent tip, because you need to see clearly, very clearly, the tip of the fiber. So personally, I recommend to cut this transparent tip. And now you see the technique. You see clearly the tip of the fiber, because it's completely blue. We cut the transparent tip. I'm using the long pulse duration 1 joule 10 hertz because I prefer the distance technique. I mean that I activate my laser far away from the tumor, and then I'm moving to the tumor. And when I see that the tumor is blanching, as you can see now on the video, I keep the distance. I don't touch the tumor. And if you do that, you will completely vaporize. I don't think it's a good word to say vaporize. It's not exactly the good term. But you see that there's small debris moving away, and there's almost no bleeding. But the trick is really respect the distance. And if you do that, you will minimize really the bleeding. Now you have exactly another example into the kidney, into the renal pelvis. You see it's a relatively large tumor, something a little bit less than 2 centimeters. And we do the same. We activate the laser far away. You see that we cut the transparent tip to be very precise. And then we are moving to the tumor. And when we see that the tumor is blanching, again, we just stop. We keep this distance. And by the time, you completely treat the tumor with really minimal bleeding. So keep this message, keep some distance when you are using this laser. It's also possible, and especially when you are into the ureter, not to be completely perpendicular. You don't touch the tumor, but you are more or less parallel to the tumor. You see that my laser fiber is not perpendicular to the mucosa, it's a little bit parallel. If you do this, you can really destroy the tumor and you don't perforate. Because the ureter, as you know, is very thin. So if you are perpendicular, there is a big risk to perforate the ureter. So to respect that, stay parallel to the tumor. And there is also another important message. Look at this lateral effect. When you are parallel, you see that the laser light diffuse a little bit laterally, and this is the reason why you can also treat this very small laser. You don't touch, and you are not perpendicular. So this is different tricks that you can use. It's also possible to do en bloc resection of the tumor using a holmium YAG, again using the same parameter, and long pulse, 10 Hz, 1 joule. It works. I must say that it's not so easy to do. I'm not a big fan of holmium YAG for the en bloc resection. And of course, it's relatively difficult to do en bloc resection into the upper tract. Not because it's not feasible, but just because it's technically difficult to manipulate your flexible ureteroscope to make en bloc resection into the upper tract. The thulium and neodymium, and holmium YAG laser. You know that we have some specific lasers with an association of neodymium YAG with holmium YAG. Personally, I have no experience, but if you ask, for example, Dr. Grasso, Michael Grasso from New York, is a big fan of this combination of neodymium YAG and holmium YAG. There's absolutely, we have few reports actually to know if it's a superior or not, but this is a combination that we can also consider. The thulium YAG, thulium YAG was initially developed for the prostate, but it's also, some people actually use it also into the upper tract. And they said that there is no difference in terms of a tumor recurrence or the free recurrence-free survival. But it's something in competition with holmium YAG. They also said that the bleeding and ureteral perforation are less with the thulium YAG versus the holmium YAG. Personally, I'm not a big fan again of this thulium YAG. I think that we can obtain very similar results in terms of bleeding and ureteral perforation with holmium if you do respect some specific tips and tricks. If you would like to know a little bit more regarding the thulium YAG, you can go to this publication of Dr. Emiliani from Barcelona. He gives some good recommendation. Thulium fiber, as you know, is completely different than thulium YAG. Don't be confused. Thulium fiber is not thulium YAG. You know the thulium fiber for stones. You were one of the first country in the world to use the thulium fiber. So there's no need for me to give you any information about the thulium fiber. Today we have a few equipment now available. The first one was the IPG, followed by Olympus. And you know that Olympus actually just produced a low power one, 35 watts. We still don't know how we have to recommend this low power system compared to the 60 watts. And also Quanta produce this fiber dust we have seen just before with KP. And Rocamed also is coming with a new thulium fiber 60 watts. For thulium fiber, for urothelial tumor, I'm using more or less the same setting. I mean 1 joule and 10 Hertz, but I'm using this time what we call the short pulse. In fact, when we say the short pulse, we are in fact talking about the peak power, as you know that. If you are using a long pulse, the peak power is going lower. So for the long pulse, the peak power is lower. Regarding thulium fiber, for the thulium fiber, with a short pulse, the peak power is 500 watts. And this is what we are using today for the stones. I'm using exactly the same for urothelial tumor, and I like it. I know that some people recommend to use the medium pulse or even the longer pulse, meaning that the peak power is something between 125 to 50 watts. I was not very happy with, maybe because I'm using this distance technique. I don't know exactly why, but personally, that's what I'm using actually is short pulse. So high peak power. That's the one I prefer today. If I compare the thulium fiber with the holmium technology, I would say that both of them are very efficient. There's no discussion. Both of them works very well. But the thulium fiber is associated with much more necrotic tissue. So if you do a big tumor, it's sometimes a bit difficult to see clearly the rest of the tumor. You have to remove the necrotic tissue before you can proceed. But there's a big benefit
Professor,
in terms of bleeding. Bleeding is almost zero with the thulium fiber. With the holmium YAG, we have much less necrotic tissue, but we have more bleeding. So, it's like a compromise between the two technology. Maybe sometimes we can also use both technology to take the benefit of both of them. It's also possible to do en-bloc resection with the thulium fiber. And I must say that I much prefer my thulium fiber actually to do en-bloc resection, and especially if I do it for bladder tumor, it works very well. We have less necrotic tissue when we detach the tumor. And again, I'm using exactly the same setting. So something interesting with this technology.
Can I just stop you for a...
Finally, I would like to conclude and to tell you that there's something very important to explain to your patient when you do this conservative treatment.
Professor Oliver, I think we're running out of time.
He's concluding, sir. He said he's
okay,
concluding.
I just conclude. Sorry for that. So for the take-home message, I would say use largely the microscope for diagnostic. Consider low-grade patient. Use digital endoscope. And consider the second look to be sure that you remove completely the tumor. And I thank you for your attention.
Hello.
Yeah, Kandar. First of all, thank you, Dr. Traxler, for that wonderful insight into the flexibles in upper tract urothelial carcinomas. I think Kandar is ready with just to take us for a minute, and then we can give it to Keshav, Dr. Keshav Murthy.
Hello.
We can hear you, sir.
Yeah, so Nanjappa, this is the vision right now. There is a nice dusting which is produced. There are no big stone fragments. I'm examining each and every calyx. So all the calyx are empty.
Wonderful, Kandar.
And yeah, we can call it a day.
Yeah, thank you. Thank you so much.
Thank you. Thank you, Dr. Nanjappa and Dr. Tanuj Pal Bhatia for moderating this session. We have a small book release function now. This book has been authored by Dr. Kandar Parekh, a coffee table book on retrograde intrarenal surgery. I would welcome the guests of honor, Dr. Mahesh Desai, the past president of the SIU and the past presidents of the Urological Society of India, Dr. Oliver Traxler, and Dr. C. Mallikarjuna, the president of the Urological Society of India. We have a 1-minute video to virtually release this book. After that, I would request Dr. Mahesh Desai to speak first, then followed by Traxler, and then Dr. Mallikarjun. Ravi Jain, can you play that video? Thank you, Dr. Ravi Jain, for that. I would now request Dr. Mahesh Desai to release this book and speak a few words. Over to you, Dr. Mahesh Desai.
Hello, can you hear me?
Yes, sir, we can hear you.
Yeah, Keshav Murthy, thank you very much for inviting me, and welcome all you are. Kandar has been demonstrating the RIRS. Well, RIRS has picked up, and it is getting a common practice in our armamentarium. It is very important to use. As Oliver was stressing every point of technique, which is very important to get a maximum out of it. And Kandarp has very nicely compiled this book of a basic RIRS, like ergonomics in RIRS, intrarenal pressure, laser, instrument, practical tip for the practitioner of the field, and discussion of the tricky situation. The knowledge is an amalgamation of the things he has learned from a great teacher like Oliver, and from the world over, and from the practical experience. This is an extremely good thing for a beginner to go through this book and then look at the videos and then follow them, and you can do the practice. And RIRS is most rewarding surgery if you do it properly. And it gives me a great pleasure and to release that book, and of course congratulate the USI and the Kandar for doing this thing for the students. Thank you very much.
Thank you, sir, for your inspiring words. Now I invite Professor Oliver Traxler to say a few words for releasing this book. Over to you, Dr. Oliver.
Yes, thank you again for the invitation. And I'm very happy to be with you also to release this book. I must say that my friend Kepi, I just remember when we meet with Kepi many years ago, and discussing about flexible ureteroscopy, and to share some experience, some tips and tricks, technical things. I think that Kepi did a fantastic job with this book, just to offer to all the people all this knowledge that he was able to put on this book in terms of instruments, in terms of technique, tips and tricks. That's so important in endourology. All the details are so important that we need to share, all of us, our experience to improve each of us our technical skills. And Kepi did it. I'm so proud, I'm so happy to see what Kepi did since many years. I would like really to congratulate Kepi for that. And I think that this book will have a huge success. Really, bravo, as we said in French, Kepi, fantastic job.
Thank you, Professor Oliver, for your inspiring words. Now I would invite Dr. C. Mallikarjuna, President, Urological Society of India, to say a few words. Over to you, Dr. Mallikarjuna.
Thank you, Keshav. It was good morning, Oliver, and it's wonderful listening to you. It's quite some time, and thank you, Sir Mahesh, sir, for spending all the time today in the morning. And it was a fantastic workshop, as we all know. KP has done a great job as usual, which is bravo, try to the power of 2 or to the power of 3 this time, I think. Wonderful. And it's I think that a nice workshop and a fantastic selection of cases and demonstration of equipment. Wonderful. I think we have a pleasure today, Keshav, to...
Hello.
Yeah, go ahead.
Yeah. Now, Dr. Kandar Parikh wants to say a few words. Over to you, Kandar.
So, thank you. First of all, I pray Almighty for giving me this opportunity and blessing me to conduct this workshop and releasing this book. So thank you, God, for these wonderful blessings. And I'm also thankful to Urology Society of India and ISU for allowing me to release this book in a workshop organized by USI. And what can be more satisfying than Professor Dr. Olivier Traxler and Professor Mahesh Desai, and with our surgeon par excellence, Dr. Mallikarjun, releasing this book. I think whatever I have learned from Professor Traxler in my interaction with him during my visit to his center, as well as listening to him in many conferences, watching his surgery, reading his literature. So I'm indeed grateful to Professor Traxler for whatever support he has given me, and I'm extremely thankful to our teacher, Dr. Mahesh Desai, sir. I think who needs no introduction to urology world because he is one of the giant figure in the field of endourology known world over. So thank you, Dr. Mahesh Desai, sir, for this honor. And finally, the Secretary of Urology Society of India, my friend Dr. Keshav Murthy, for taking so much pain for this program, and my friend Dr. Rajiv Sud and Dr. Chawla from ISU for allowing me to do this book release. Actually, I am also thankful to my three associates, Dr. Rahul Soni and Dr. Ravi Jain, also helped me a lot in editing book, and my son Aditya, he did the final reading and correcting so many mistakes, spelling mistakes or the grammatical mistakes I did. So thank you, three of you. Without you, probably this work could not have been finished. This book is released only as a part of knowledge sharing. I was inspired by a book, Die Empty, and the book says that if you have idea, perform it. If you have knowledge, share it, and if you have love, distribute it. Die empty. So we have to know, we have to distribute among our colleagues whatever we know, and we are in a constant process of learning. So I'm also learning from so many young dynamic urologists as well as from the doyens in the field of endourology like Dr. Michael Grass or Dr. Begley. So I'm really thankful to all the people who have contributed. I must say thanks to my friend Saeed who joined us, who was also a fellow with Dr. Traxler, and he is doing fantastic job in Saudi Arabia. I would, as a part of knowledge sharing, we are conducting minimal access training programs regularly in my hospital, and I'm happy to say that more than 200 plus urologists from the country have attended the RIRS training programs in my hospital. Um, and finally, when we thought of releasing this book, we thought of sharing, distributing this book completely for free to all the members of Urology Society of India who would like to obtain this book. And I'm really happy to say that in a 1 week time, we have a request from more than 101 Urology Society members to get this book. So thank you, USI members, and I'm sure that this book is going to be very, very helpful to you. And I dedicate this book to my father, who was a professor. So teaching is in my blood, and he was a very well-known author of Gujarati literature. So I dedicate this book to my father. And finally, I'm thankful to my staff members. I think they have worked really hard for this workshop as well as for this book. So thank you so much. And finally, Indas, who has sponsored this book, because to publish this book of this magnitude is impossible. So the book is supported by Minimal Access Surgery Training Institute and Intas Pharmaceutical. They have decided to print out the copies and distribute it to all the urologists who request this copy. Thank you so much, USI, and I'm really overwhelmed with the kind of response I have got. And thank you all moderators for today's session. Thank you so much.
Thank you, Dr. Kandab. It's wonderful that you have authored this book. Now I would invite Dr. Arun Chawla to give his concluding remarks. Over to you, Dr. Arun.
Thank you, Dr. Keshav. At the outset, congratulations to USI and Dr. Kandar Parekh for having an excellent operative workshop. Not only focusing on the skills used for the RIRS, but covering comprehensively right from the guide wires, the access sheet, the type of scopes, the energy devices. I think this is going to be immense benefit to all who are learning this procedure, and the one who are doing this procedure, probably they will also gain some proficiency in making this procedure safe and effective. Secondly, the congratulations to the author of this book, Dr. Kandar Parekh, and congratulations on this occasion of your book launch. I think your book covers almost everything which is needed for somebody who wants to do this procedure, learn more about, or want to increase his, what you can say, efficiency and proficiency, with the emphasis on the instruments, the technique, as well as the tip and tricks from yourself mentioned in the book is going to be very helpful. And
Hello. Arun, your audio is not.
I think there was a problem there. Okay, sir. Thank you, Dr. Keshav. At the outset, congratulations on behalf of USI and Indian School of Urology to Dr. Kandar Parekh for an excellent webcast covering the two important procedures, not only focusing on the skills of the procedure involved, but as well as covering the armamentarium right from the guide wires to the access sheet to the instrument as well as the energy. Excellent viewing by the audience, the numbers crossing more than 300, both from India as well as abroad. And secondly, the congratulations to Dr. Kandar Parekh for authoring a book on the RARS. We have some books on the percutaneous management of the renal stones, but on the RARS, there are hardly any books, and I think this is going to be immense benefit to the younger surgeons or to the surgeons who are undertaking this procedure. With the comprehensive coverage on the instruments, the techniques, and the tip and tricks from the Master Craftsman KP is going to be of immense benefit in making this procedure safe and effective. I think with this, I congratulate Dr. Kandar Parekh, USI, Dr. Mallikarjunan, Dr. Keshav Murthy, and the faculty who participated in this webcast, and the viewers who stayed live during this procedure. Thank you. Over to you, Dr. Keshav.
Thank you, Dr. Arun. Is Dr. Rajiv Sood there? Dr. Rajiv
Yeah,
Sood?
yeah,
he's there.
Yeah.
Over to you, sir, for your remarks.
Yeah, thank you very much. It was wonderful workshop and so well attended. As Dr. Arun is mentioning that more than 300 people have continued watched it. It was expected also, and the faculty which was chosen very carefully, and program is well crafted. It was wonderful time. We are all thankful from Indian School of Urology for this workshop participation, and also Dr. Kandar Parekh, who is to be congratulated for his all the efforts in this, and he has always been contributing to our Euromet programs. Euromet programs are coming now, 3 in a row in next 2 months, because the physical facility is open now in Olympus, and we will be contacting everybody and sending the flyers with the dates. Be tuned and for this, and be prepared to participate more and more through your residents and also consultants in these programs, where we will be able to meet again. Thank you very much. Thank you for today.
Thank you, Professor Sood. And I must thank on behalf of the Urological Society of India, Dr. Kandar Parekh and his team in the theatre, anesthetists, the technicians, nurses, and his associates for a wonderful workshop. And I must also thank the audiovisual for giving a wonderful transmission. And let me thank the support from our office, Navneet and Kiran Arora, for the logistical support. Thank you all. Good afternoon.
Good afternoon. Thank you.